Welcome everyone to the Comprehensive Spine Course being organized in Lucknow, and I'm sure this session is going to enlighten us all about more and more tips and tricks about the most complex endeavors in spine surgery, spinal deformity. Scoliosis and kyphosis have more been an enigma enough to create more resistance among even the most established spine surgeons purely because of lack of knowledge about the basics of scoliosis and kyphosis surgery. I am sure surgeons who indulge in the spinal deformity surgery will vouch for it that they are more satisfying, more successful than the most commonest spinal degenerative spinal disc surgery. And so, to learn more about the nuances of one of the surgeries which produces most amount of satisfaction among patients and surgeons, I have a wonderful panel of spine surgeons from across the country. May I welcome upon Dr. Sandeep Chatterjee from Calcutta, Dr. Amit Jhala from Ahmedabad, and Dr. Jacob Matthews, the young guy from the south of India, Kerala. So may I welcome upon you all to please join us as the panelists. Who else to start the session but the master blaster, Dr. Arvind Kulkarni, who's going to tell us about how do we assess radiologically a patient with spinal deformity who's come to your clinic. How do we start? What do we see in X-rays? Over to you, Dr. Arvind Kulkarni.
Thank you, Vishal, for this great introduction. As you said rightly, every spine surgeon has to be a deformity surgeon. Unless you understand the nitty-gritties of spinal deformity, I don't think you'll be doing justice to evaluation of any patient with or without deformity. So thanks for giving me this topic, but he wanted me to talk on the basics of deformity calculation in sagittal and coronal place. But when I started making this presentation, I didn't know where to start and where to end. It's a very big topic. So I tried my best. Please start my video. Thank you.
AV team, please start Dr. Arvind's video, please.
Dear friends and colleagues, first of all, I would like to thank the organizing committee for inviting me to deliver this talk. Let's classify this into pediatric and adult spine deformities because both of them are different entities in their own right and have different paradigms. So first, let's discuss assessment of pediatric deformities under the following headings. The goals of pediatric spine deformity correction are prevention of progression, cosmesis, balance, achievement of solid arthrodesis, and most importantly, saving levels. So it's very relevant that we assess the magnitude of the curve on upright erect films and not on supine X-rays. First of all, we need to understand the magnitude of the curve. How do we measure it? So this is the angle between the lines formed by the superior end plate of the most cranial end vertebra. So that is the vertebra which is tilted maximum into the curve at the cranial end with the line which is along the superior or inferior end plate of caudal end vertebra. So that is the vertebra which is tilting maximum into the curve at the caudal end. So this particular angle is called the Cobb's angle. The vertebra which is most horizontal, which is at the apex, which is most rotated, which is most displaced, is called the apical vertebra. So once the magnitude is measured, and when it comes to management of this particular curve, so we need to check how flexible the curve is. So in small magnitude curves which are less than 60 degrees, we depend on convex side bending X-rays. And for larger curves, we depend on the traction X-rays. And how do we measure the flexibility index? That is using this formula, that is erect curve minus flexibility curve divided by erect curve. So assessment of shoulder level is very, very pertinent because you might get a very good deformity correction, but the shoulder may be hanging up or down, and this can ruin the success of surgery. So it all depends upon the preoperative shoulder level. So usually it is the right-sided thoracic scoliosis that is seen in idiopathic curves. And in this situation, if the left shoulder is high, the fusion should extend up to the T2 level on the left side. This is basically to pull the shoulder down after getting a correction. If the shoulders are level, again it is a challenge, because after correction of the right thoracic curve, the left shoulder might again go up. So in this situation, it is advised to go to T3 or sometimes even T2. The best favorable situation is when there is a right thoracic scoliosis and the right shoulder is high. So when the curve is corrected, the right shoulder will come down and the left shoulder will automatically go up. In such situation, one can probably stop as low as T4. But all these formulae come with certain riders. So it depends upon where the apex of the thoracic kyphosis is located, because you need to go above that in terms of instrumentation. You also need to check the magnitude of the curve that you're correcting. If you're getting a very significant correction and if the magnitude of the curve is extremely high, so then even if it is a right-sided high shoulder, so the left-sided shoulder might go so high that you need to pull it down. So in such situation, we might still have to go up to T2 even if the right shoulder is high preoperatively. So it's very important to know the balance, how well the curve is balanced. This will give an idea as to whether the curve is compensated or decompensated. So for this, we draw a C7 plumb line. So this should usually intersect with the CSVL, that is central sacral vertical line. If it is not, then the curve is decompensated. We need to know how much the apical vertebra is translated from the midline. So for a thoracic curve, you measure it from the C7 plumb line, and for the lumbar curve, you measure it from the CSVL, that is central sacral line. So Harrington stable zone concept is very important, because the last instrumented vertebra should fall in this particular zone. So this is a zone which is defined by parallel lines drawn through the lumbosacral facets. The vertebral bodies within the lines are in the stable zone. So your foundation will be in the stable zone, upon which the scoliosis deformity is corrected. So this is an extension of the Harrington stable zone. So this is called the lumbar modifier, which comes under the purview of linkage classification. So we need to draw a CSVL in a coronal, that is a AP radiograph. This is basically to assess the magnitude of the lumbar deformity. It more accurately assesses the need for and the method of correction of the lumbar deformity. It has a role in selecting levels of fusion and deciding selective fusion. For example, if the curve is such that the lumbar apex lies is of A type or B type, then you don't have to include the lumbar curve in the correction. But if it is a type C curve, in certain situations you can do a selective fusion, or in certain situations you need to include the lumbar curve also. So this is to illustrate the lumbar modifier. So on the extreme left is type A, in the middle is type B, and at the extreme end is type C. So they either go in the midline, it passes through the midline, through the spinous processes, or between the spinous processes and the pedicle, or beyond the vertebra. Now, what is this concept of selective thoracic fusion? So, to maintain the mobility of the lumbar curve, sometimes in a double curve, you can just fuse the thoracic spine, and this, by correcting, rotates the lumbar spine to correction indirectly. So, this is possible in certain situations where the magnitude of the thoracic divided by the lumbar curve in terms of cob, in terms of apical vertebral rotation, in terms of apical vertebral translation, the ratio is more than 1.25. So this is an important concept again, that is pelvic obliquity. If the pelvic obliquity is significant, especially more than 15 degrees, it is suggested that the instrumentation and fusion should extend all the way till the pelvis to have a balanced pelvis. This is usually seen in neuromuscular scoliosis. So this is an example wherein you can see there is significant pelvic obliquity close to about 60 degrees. So the balance was brought about by correcting the curve and fusing all the way till the pelvis. So again, we have the thoracic modifiers which need to be considered when you're doing a scoliosis correction. Ideally, one should do a Stagnara's view, but practically it is not possible because all curves, scoliotic curves, idiopathic, are lordotic in nature, hypokyphotic in nature. So to really check the lateral view, one needs to take an oblique view, which is called the Stagnara's view. But as I said earlier, it is of no practical importance. Again, this is a very important concept when it comes to the sagittal orientation of any deformity. So again, similar to the CSVL, we have something called as a sagittal stable vertebra concept. So this is basically a line drawn from the posterior aspect of S1 end plate vertically up, which is called the posterior sacral vertical line. So the vertebra which is bisected by this particular line is called the sagittal stable vertebra. So whether you're doing a kyphosis correction or a scoliosis correction, your distal instrumentation should not be short of this particular vertebra. Otherwise, there is a high chance of distal junctional kyphosis. So let's take an example. This is a girl with a 77-degree thoracic scoliosis and a 55-degree lumbar scoliosis. It's a double curve. She has a significant rib hump and her right shoulder is high. So as I said, this is a curve which is more than 60 degrees. So the convex side bending doesn't reveal the exact flexibility. It reduces to just 70 degrees. But when you do a traction X-ray, not only does it reduce to almost 37 degrees, but the lumbar curve almost disappears, giving an idea that this can be treated with selective thoracic fusion. Another important uh, uh, aspect of this particular curve is once the traction is given, you will see that the left shoulder is going up. So when you're planning, though the preoperatively the right shoulder was high, one needs to go to T2 to pull it down because the traction giving X-ray is giving us a hint that there could be a overcorrection with which might result in the left shoulder going high. So this patient underwent a selective thoracic fusion all the way up to T2, and you can see the lumbar curve is very well corrected. So when it comes to correction of kyphosis, there are various angles described to measure kyphosis. What is important is to do a standing X-ray and also a supine X-ray, which is an extension, to assess the degree of mobility of the curve. Again, as discussed earlier, it is important to instrument till the stable sagittal vertebra. Otherwise, there will be a distal junctional kyphosis. For example, in this patient with Schurman's kyphosis, he was having significant deformity and back pain. He underwent a correction which was short of sagittal stable vertebra. The sagittal stable vertebra was at L3, but he was fused short of it by two vertebrae. So he developed distal junctional kyphosis and then underwent a second revision surgery to correct the deformity. Now let's go to adult spinal. It's very important to understand the conus of WSA. Basically, the internal smaller conus, which is the equilibrium economic conus, this is where the subject maintains a relaxed upright posture with minimal expenditure of energy. The external larger conus represents the position where the subject has to activate erector spinae muscles to maintain an upright posture. The larger the diameter of the base of the conus located at the level of the head, the greater the effort that the muscle should exert to keep the body upright. It's very important to understand the concept of sagittal vertical axis. So the C7 plumb line ideally should pass through the sacral end plate. So in patients with global deformity, especially in adults, what happens is the spine droops forward and we need to measure the degree of malalignment. So this is called the sagittal vertical axis. So this is the distance between the C7 plumb line and a line drawn along the posterior superior S1 corner. Ideally, this should be less than 5 centimeter. So for example, you can see there is a significant sagittal imbalance because the C7 plumb line is quite ahead of the sacral end plate. And one of the goals of correction of adult spine deformity is to get it in line with the posterior superior corner of S1, which is achieved here. So adult deformity is very interesting. It is a result of the degenerative cascade. There is asymmetric degeneration resulting in asymmetric weight bearing by the discs and the facets, which usually results in spinal stenosis. The loss of disc height plus the other degenerative changes plus the spinal stenosis leads to loss of lumbar lordosis, causing actually lumbar kyphosis, along with which you will get to see compensatory thoracic hypokyphosis. The pelvis goes into retroversion, the hip indirectly goes into hyperextension, and the knee flexes to maintain the sagittal balance. So these are all the compensatory mechanisms. So there are many papers to show that patients who have sagittal imbalance and who have developed compensatory mechanisms have poor ODI, and again when these mechanisms and deformity are corrected, the ODI improves. So goals of adult deformity correction are achievement of sagittal and coronal balance, to get the spine and the body into the conus of economy, to achieve a solid fusion, and also achieve adequate decompression to relieve the patient of neurological compression. So it's very important to understand certain concepts here, that is a pelvic incidence, which is constant for each individual. It is 52 degrees as a mean. So that is the angle between the perpendicular to the superior end plate of S1 passing through its center and the line connecting this point to the axis of the femoral head. The sacral slope is defined by the angle between a line tangent to the superior S1 end plate and horizontal line. Vertical pelvis implies a low sacral slope, while a horizontal pelvis would have a high slope. It is approximately 40 with a range of 20 to 65. It changes with compensatory posture. And most importantly, the pelvic tilt is the angle between the vertical and the line connecting the center of sacral end plate to the axis of the femoral heads. The angle is positional and related to pelvic orientation. The pelvic tilt angle increases during retroversion of the pelvis. So it's approximately about 12 degrees with a range from 5 to 30 degrees. The pelvic incidence is equal to arithmetic sum of the sacral slope and the pelvic tilt. Patients with a high pelvic incidence angle have a greater potential for pelvic retroversion. Lumbar lordosis is pelvic incidence plus or minus 10 degrees. This is an important concept when analyzing compensatory. The correction of adult spinal deformity using radiological parameters is best exemplified with this particular illustration. So there is a sagittal vertical axis of 10 centimeters. Now, in order to correct this deformity, we need to do an osteotomy. So this, suppose we are planning the osteotomy at L4. So we need to not only add angle A, so that is angle found by the C7 plumb line with the SSVL, but we also need to account for the pelvic tilt compensation here. So the pelvic tilt here is 40 degrees. So the ideal pelvic tilt, if you consider is as 20 degrees, so difference in the pelvic tilt will be 40 minus 20. So the osteotomy angle at L4 would be A plus the difference in the pelvic tilt, that is 40 minus 20, which is equal to 20. So A plus 20. So this is included in this Schaub's classification when you plan to correct adult spinal deformity. But however, there are some limitations of Schaub's classification, which is compensated by this new score, which is called the GAP score, which is beyond the time limits of today's. So the take-home message is pediatric and adult spine deformities are two different paradigms. They have different indications, but many similar goals, basically of getting a sagittal and coronal balance. Every day there is evolution of new clinical and radiological criteria to achieve perfection, and this evolution will continue till we get perfect, fair, and square. Thank you.
Thank you, Arvind, for a comprehensive talk on radiological evaluation in spinal deformity patients. Before the slides for another speaker comes up, which is Dr. Shankar Acharya, may I have a question for you, Dr. Arvind, and another one for our senior panelist, Dr. Amit. So, Arvind, a patient of spinal deformity walks into your clinic with a right-sided thoracic hump in a 15-year-old female. What are the basic X-rays that you advise that this patient must get done before you evaluate this patient?
So the first time the patient comes to me, it will be a erect film. It should encompass the head, the entire trunk, and the pelvis. And in the lateral view, it should include all this. Plus, it's very important that the knee is in extension.
Right. So you get to do a PA and a lateral view, full spine, along with head and the knees included, with the knees extended. That is a very important point that we all must carry. How often do you do X-rays in these patients? Like a patient comes to you and you see that the deformity is 30 degrees. Then how often do you call them a follow-up?
So age is also important. So if the magnitude of, for example, the right thoracic curve is 30 degrees and the patient is about 10 years and she's short of menarche, and if a risser is in a lower side, so then I will call her again after another 6 months to observe if there is any progression. But if she is already an adolescent, her risser is 5, and if she is 16, 17, most of the times, 30-degree curves are not do not progress. So I will just leave her alone.
Like, very important. And how about flexibility X-rays? When is it that you really ask for flexibility X-ray, dynamic views? Is it on day one or after a certain while?
Yes, so it's very important that we radiate the patients less and be very calculative and smart about how we, get our X-rays done. Many times, unscrupulously X-rays are done right, left, center. So this is done only when I'm going to operate on the patient.
Right.
When I'm going to decide, so when I'm going to operate, I need to see the flexibility. That is when I'm going to do the bending, side bending and traction X-ray.
And what is your threshold when you start thinking about surgery? Is it 30°, 45°, or 60°?
So 45° probably is my threshold, even after skeletal maturity, because in these cases, along with we also need to take into consideration the rib hump. So the deforming structures are basically the shoulder, not just the curvature, the comprehensive picture of the patient, whether where the shoulders are, what is the rib hump. Sometimes the curve is just 40°, but the parents are very bothered about the rib hump, about the shoulder, about the waistline. It is lopsided. So these all things need to be considered, and as we all know, we need to sit down and counsel the patient's parents, etc., and come to a decision.
Interesting. Thank you, Arvind. AP view, PA views, lateral views, and bending views are the basic film that have to be done. Do not repeat them very often. Minimum difference of 6 months if the curve is less and the patient's growth potential is less. However, you can do it at 6 monthly interval. Always do a proper X-ray, and not only radiological but clinical evaluation is extremely important when you are assessing these patients. Surgical indications depend not only on the magnitude but also on the growth potential of the patient. Dr. Amit, one question before we move on to Dr. Shankar Acharya is, now you've got a PA view of the patient. You are seeing a right-sided thoracic hump and right-sided shoulder high. What are the angles very specifically? How do you draw lines, and what are the essential angles that you must draw on the X-ray before you plan for any surgical measure or any decision making?
I think the most of the important X-ray angles that I draw are three angles that I draw. One is the main thoracic curve angles, because as you said, it's a thoracic curve, and the other two compensatory. Unless we have these three angles, we will not be exactly knowing that which curve it is according to the classification, and where to start and where to end the instrumentation, and how much is the flexibility. So these are the three angles that are minimum which I draw on AP X-rays, as well as the same in the lateral, because sometimes you have a thoracic kyphosis or a
Thank you, Dr. Amit, for bringing out a wonderful message here. Though the curve may be limited only to thoracic spine externally, clinically, however, it is extremely important to not overlook the proximal thoracic and thoracolumbar or lumbar curves. You may actually be looking at a hidden curve, what Dr. Arvind highlighted, that the thoracic curve with a balanced shoulder, you know that there is a hidden proximal thoracic curve, and the moment you correct the thoracic curve, the shoulder may tilt to the other side, and same may happen to the lumbar. And that is why, though there is apparently only thoracic curve or a thoracolumbar curve, it's extremely important to measure subtle, innocuous, hidden proximal and distal curves always, both on PA and lateral views. We move on to Dr. Shankar Acharya. Why these slides come up? We have Dr. Ranjit also with us. Dr. Ranjit, when do you do MRI and CT scan in these patients? What are the red flags where MRIs become essential in your radiological evaluation for these patients with clinical spine deformity? Ranjit.
Yeah, thank you, Dr. Vishal. For me, every patient, when I plan a surgery or when I see a progression, has an MRI. It's not option, it is must. CT, I rarely get it done unless I am very doubtful about the dysplastic nature of the vertebra. If not, I try and avoid CT for the reasons such in that, in adolescent idiopathic, I don't need a CT because I'm not expecting any bony anomalies there. Second, these are the ones who go in for long-term X-rays till they reach maturity. So multiple X-ray, exposures. So I want to try and minimize as much radiation in them as and when possible.
Thank you, Ranjit, for bringing out a wonderful point out there. Any patient planning for surgery, please try to rule out any neuraxis abnormalities and do a MRI scan to find out if you're dealing with anything subtle which is hidden out there. May I now pass the baton to none other than the President of Association of Spine Surgeons of India, who has not only pioneered his work in spine, but also in spine deformity by running and bringing forth the spinal scoliosis screening program across the country. And he is one man who's brought scoliosis in the front of society, and now the screening program has taken a widespread approach, and more students can be diagnosed early. Over to you, Dr. Shankar Acharya, about idiopathic classification systems.
Good afternoon, everyone. I thank the organizers of the SGPGI MS Comprehensive Spine Course, and special thanks to Sanjay Bihari, who is my very good friend, and Professor Jayesh Saradhara, who has invited me to give this talk. I understand you've had 2 days of deliberations in this virtual conference, and there are a lot of neurosurgeons in this conference. My job is to tell you about the AIS classification. You already know about how to measure angles, what are the curves, what is the alignment, and everything else. And my job is to tell you about the classification and the surgical fusion levels, decision making of what to do when. This is not easy to cover in 12 minutes. However, I will try my best to take you through to the basic principles of surgery. I think the first most important thing is that whenever you do a scoliosis surgery, this is a large surgery, time-taking surgery. There's a lot of blood loss in this. And so it is important to understand the patient whom you are going to take up the surgery so that you can ensure lowest morbidity, least number of vertebra fused, have a good sagittal and coronal correction, and prevent further progression. So when you aim for this surgery, then you should have all this in your mind, and you must counsel these patients up for this major surgery. And at the end of the road, your cosmetic results must be better than your radiological outcome. The ideal surgical result is the one where you have the top and the bottom of the fusion mask should be in the stable zone. This was first taught to us by Harrington when he said that it should be in a stable zone, which means if you look at us curved, so scoliosis X-ray, and you put your hand on the curve, and then you can find out that the above and below curve is straight along the pelvic central sacral vertical line or in the Harrington stable zone, you know that it's in the stable zone. The shoulders and the pelvis should be level. And if the fusion goes down to L2, you must make sure that the vertebra is horizontal and neutral and the disc is centered on the sacrum. That's very important. Otherwise, you'll get add-on and coronal decompensation. So basically, it all started with fusion of major curves. And so major curve was defined, and I'll come to that later, from cephalite neutral to caudal neutral. So Harrington said you'd fuse neutral to neutral major curves, and the minor curves or the non-structural curves could balance itself. And that is important to keep in mind when you are doing fusion. So, and also your distal fusion should never end in a kyphotic disc space. So that is why sagittal concepts were introduced by Lenke, and because that was not taken into account in the initial Harrington, would led into flat back, and in the King's classification was basically for thoracic spine. So, and try to leave as much as distal motion segments for lumbar flexibility. And that is how we come to fusion levels. So coming to the classification, there are basically three major areas which you require. So when you see a child with scoliosis, you must first find the age of the child and the growth at which the child is. Then you must look at the balance of the child, the cosmetic balance, the shoulder, the pelvis, the flanks, the arms, the hips, where what is in balance, what is out of balance. Because you can have a lanky 1C, which is well balanced and finish the growth curve, and you may not want to do anything in those. And then you will, the largest curve, even if it is flexible, is the major curve. And other curves, which are either flexible or non-flexible, are called structural or non-structural curves. So this is the Lenke's classification. And it is important to go through this slide a little bit in detail. So Lenke said that there are 6 curves. So first is the major thoracic curve. The major thoracic curve is a thoracic curve, which is a long curve. So it can be anywhere between the apex, depending on the apex, it can be anywhere between T2 to T5 to T11, 12 disc, and that is the major thoracic curve. So that is the first curve. Then is the double thoracic. So if you have a proximal thoracic, which is become structural, that is a double thoracic curve. And if distal to the thoracic curve, the thoracolumbar has become structural, it is a thoracolumbar or a double major curve. And then type 4 curve is a triple curve, which is structural, which is very rare. So you just see about 1% of these curves in your clinical practice. The maximum 60 to 70% are type 1. So this is important to understand. And that is where selective thoracic fusion and other things come in. Type 1 form about 50 to 60%, type 2 form about 15 to 20%, type 3 also 15 to 20% or 10%, and type 5 is about 10%. So type 6 and type 4 are very rare, 1 or 2% each. That was the first criteria. The second criteria was, since we are seeing in clinical practice mostly type 1 and type 2, you are looking at the lumbar coronal balance. So so that's why he put in a lumbar modifier. So if the central sacral vertical line is between the pedicles, that is, you look at the lumbar curve, you look at the lumbar vertebra, which is laterally deviated and horizontal, that is at the apex, near the apex, and that is the you have to check whether the central sacral vertical line is passing through the pedicle, is deviated from it, or it is outside it. So that is how you have lumbar modifier A, B, and C. Then, as I said, since type 1 curve is the commonest curve, if it and it comes as a major thoracic curve, over a period of time, the proximal thoracic and the thoracolumbar may become also structural. And that is how you get type 1 and type 2 and type 3 curves. And it is important that sometimes something which may be looking like a type 1 curve may be having kyphosis. So Lenke put in the sagittal modifier, so that if there is in T2, T5 proximal thoracic, the kyphosis is more than 20 degree, then that is also called a structural curve. And similarly, in a thoracolumbar area, if the T10 to TL2 kyphosis is more than 20, that is also a structural curve. So this is also important to keep in mind. So first you will see which is the curve, then you will see what is the modifier, then you will check what is the sagittal profile, and then you will classify this. So as I said, type 4 and 6 are less common. You find mainly type 1, and type 1C is when you have an adult, when you have a completely S-shaped curve where both may be balanced. So these are things which you'll have to think about whether you want to offer them surgery or not. Normally, we offer surgery when the curve is out of balance, more than 50 degrees, some growth is remaining, the pelvis is the shoulders are not in balance, and you know that the curve is growing. So coming to fusion, I think it is important to spend a few minutes in this fusion. First, Harrington, as I said earlier, Harrington in 1966 said, well, the Harrington rod was you fix from stable to stable zone. So he drew a line parallel along the sacral facets up, and the fusion mass should be in the stable zone. Then Moe introduced the concept of neutral vertebra. So neutral vertebra is the vertebra in which both the pedicles are neutral. So that is normally below the end vertebra of the curve. We all know how to measure the Cobb's angle, and we know which is the apical vertebra, which is the neutral vertebra, which is the end vertebra, which is the stable vertebra. And then the Suk found that the neutral, if you start in by 2003, he was using pedicle screws. So on all pedicle screws construct, he found that if you use just pedicle screws right up to T1 or T2, then you could, and distal lower end vertebra, you could go cranial to the neutral vertebra, 1 minus neutral vertebra. Now coming to which should be the upper instrumented selection. As I said, type 1, 3, and 6. There the proximal thoracic curve is non-structural. So depending on the shoulder balance, you can decide where to end your fixation. So for these, there is a standard rule, which if you want, there are lots of rules in this, and there are lots of dilemmas in this, because I'll come to the 2 and 4 now. So if you go for a standard rule, if your left shoulder is high, then you go up to T2. If for a neutral shoulder, you go up to T3, is balanced. And if T4 is for a high right shoulder. So that is what is a standard formula for type 1, 3, and 6, because the proximal thoracic curve is flexible or non-structural. For type 2 and 4, which 4 is very rare, as I said, for type 2, which is a double thoracic curve, it all depends on the rigidity of the proximal thoracic curve. And there is a lot of debate on that, and even I am not sure as to what is to be done. But essentially, you must include a rigid curve, as I said initially. So your structural curve should be included in the fusion. So you can include both the curves. However, what is more important is that if there are two things here in the shoulder balance. One is the medial shoulder balance, one is the lateral shoulder balance. So medial shoulder balance is depending on the T1 tilt. So if the T1 is tilted higher and the left side is higher, that is a positive T1 tilt. Similarly, if the acromion is tilted higher than from the right side is a positive shoulder tilt. So that is important. And also the shoulder morphology is looked into. So the cosmetic picture of the shoulder is also important because that is what the patient feels or sees. And that is important to keep that in mind for type 2 and 4. Type 5 is a lumbar curve, so that the upper end vertebra should not go beyond the lumbar curve. Coming to the lower instrumented vertebra, there are some new terminologies which have been brought in. So basically, there is a lot of controversy because, as I said, the most common scoliosis is the major thoracic, so type 1, then comes type 2, and so from type 1 to type 4, you have a similar lower instrumented level, but it all depends on the sagittal profile and the rotation on selecting the LIV, and that is important. So if you look at this Indian Spine Journal, which is the last issue, which is a symposium on scoliosis, you will find that Lenke himself has written this chapter. We've invited him. And he puts in a table of 15 possible solutions. So essentially, to keep it nice and simple, there are two terminologies which have been introduced. One is the last touched vertebra of the CSVL, or the last substantially touched vertebra or neutral vertebra. It is always safest to have your LIV at the neutral vertebra. However, if you use the neutral vertebra, you will not be saving motion segments. So substantially touched vertebra, which normally is above the neutral vertebra, not always though, and that would be medial to the pedicle. Last touch vertebra is if the CSVL is just touching any part of the vertebral body. And so you will have to consider when and where, depending on the balance, the rotation of the lumbar vertebra, and what level. Is it junctional? It is better to be out of the junction. So also the sagittal profile, you should look at last lordotic, most proximal lordotic lumbar vertebra, or just stable sagittal vertebra. So that is also another concept which is important. So these 4 or 5 things have to be looked when you are considering the LIV. Since Lenke 1A curves are quite common, there is an adding on. He found I think Newton did a study and he found that the L4, so normally you have a right-sided thoracic curve in a type 1, and so the lumbar curve should be left-sided. However, there are situations where the lumbar L4 is tilted to the right side. And in such situations, you may get add-ons. So that is important to keep in mind. So there was a sub-classification of the type 1, which is 1A R curve and 1A L curve. Let's take some examples. So I've told you about this classification. I've told you about the upper instrumented level and the lower instrumented level. And I told you the philosophy about it. Now, let me take you through some of my cases so you can understand it better. And you always don't have to follow the rules. Sometimes you may have to break the rules, especially to preserve motion segments or to create balance. Sometimes you may have to go more and less. So this is a child with the right-sided main thoracic curve. This is a Lenke 1A, right shoulder up. Apex was at 10 level. So the major thoracic curves have a long curve. So they can be long, they can be short. The apex can be higher, it can be lower. So that is all very important to keep in mind. The T1, T5 was a minor non-structural curve, and the main thoracic structural curve had a curve of 76. So these are the bending films, as you can see. So this has a lumbar modifier A. Now, if you look at this slide, and if you look at the green line, which is the CSVL, you can see that the stable vertebra is L3. Right? And that is also the neutral vertebra, and more or less neutral vertebra. Then substantially touched vertebra is L2, and the last touch vertebra is L1. So you can always debate in mind in order to save levels, but then you have to take everything into consideration. And his coronal balance is +3. So we did for to L3, and we had a good balance in this patient. This is another child, Lenke 1A, and 14-year female. And this is the curve. I'll have to go quickly because I see I'm running out of time. T1 to T4 is 26. T5 to T11 is 60 degrees. And T12 to L4 is 26. But on bending films, the lumbar curve completely corrects out. And so does the proximal thoracic. So this is a type 1A. And because there is no kyphosis and there is normal alignment. So So the neutral vertebra and stable vertebra are L2 in this. And so we fixed it from T3 to L1. And you can see there's a good alignment in this case. So this is another case. This is Lenke 2. So Lenke 2 is a major thoracic and a thoracolumbar curve. And you can see the thoracic curve measures 33. The thoracolumbar curves measure 73. And these are the bending films. So both the curves are major curves. And here the stable vertebra was L5. And if you look at the CSVL, here you think you're a dilemma. Will you fuse to the stable vertebra? Will you fuse to the last substantial vertebra is not there, that is this L5. So, but the L4 is large test vertebra. So we have gone to L4 in that. So there was a good coronal balance. So this is because you want to save levels and you have to think twice. This was already reserved for, so you have to think twice before you want to go to L5. And especially T1 and L5, you have to think 2-3 times really before you want to go into them. So this is a 2-year follow-up of this patient. I have a longer follow-up, but I haven't got the pictures now. So this is a 3B, and I'll quickly go through this pictures. There is a T1 curve, the T1 to T5 is 24. So this is also important to keep in mind. The lateral bending films are supine bending films. So sometimes the proximal thoracic bending may not be very good and may not be either by the radiographer or by the patient himself. And so these may be a challenge. So that is also important because there are so many ifs and buts in there. The neutral vertebra was L5. And I was, as I said earlier, I'm very reluctant to go into L5. I went to L4. And we used in proximal thoracic, sometimes you can use a hook to try to bring it down and a pedicle screw to try to derotate it. So I've used this combination. Another curve, this is a 4A curve. I think I will skip 4A because this is less common. However, just to show you in these large curves, you may have to do a longer fixation. And still here, as you can see, I have left the L4. There's a 12-month follow-up in this, and the patient is otherwise cosmetically happy. You can see this X-ray hole standing film and this well-balanced shoulder and well-balanced pelvis in this patient. Coming a few lines on thoracic or thoracolumbar selective fusion. So selective fusion we normally would do for a major thoracic or a type 5 lumbus. So, but however, as I have already said, we always want to save fusion levels. So you can also do selective fusion for Lenke 1 to 4 sometimes. And Lenke 1 and 2, most of the times you want to be as selective as you can. However, the Lenke has laid down some criterias so that basically the lumbar selective means you are leaving as much mobile segments in the lumbar spine. So essentially it should be less, the curve should be less than the thoracic spine. The curve should be less rotated than the thoracic spine. The translation should also be less than the thoracic spine. In other words, the thoracic spine should be larger, stiffer than the lumbar spine. And you can undercorrect the thoracic spine with selective fusion so that the lumbar spine also spontaneously corrects to some extent and get a balance. So that is the philosophy. And so there are some selective fusion criteria. And so the AVT ratio, apical vertebral translation, if you draw a plumb line from C7, I think Arvind must have spoken to you all about this. So the AVT, the AVR, and should be more than 1.2. So that means the thoracic spine should have a larger, stiffer curve than the lumbar spine. Waistline asymmetry should not be too much. And that is important also because you must look at the cosmetic part of it. Otherwise, it is better to tend to be on the safer side and do a longer fusion. So this is a case where this is a Lenke 1C where you can easily see this is a very good case for a selective thoracic fusion. The lumbar curves opens out. So in this, we did a selective thoracic fusion and I undercorrect a little bit, but the patient gradually compensates and corrects. This is a 5C and lumbar 5 curves. We used to normally operate them anteriorly, but now most of these patients, we do them posteriorly. I don't see so much of lumbar 5 curves in my practice. And this is a case where I still didn't go to L5. I wanted to save the level. As you can see, I'm still a little off balance. Time will say. So this is after 18 months follow-up and the patient has balanced a little bit herself. So this is a Lenke type C. This is also very unusual or uncommon. So I will not spend much time on it. And there you have to go higher up the end. So I did a longer fusion in this. Rotation is an issue here. So you will have to make sure you correct the rotation. Shoulder balance. I've already spoken about the shoulder balance. So if the upper thoracic curve is got a stiff curve, if the cob is greater than 30 degrees, if there is rotation, is apical translation, and the left shoulder elevation, and if the T1 tilt is towards the concavity of the curve, that means it's tilted to concavity, then you probably have to you have to take that curve in. However, there are some times where you can, if you find that it is balanced, you could leave that proximal thoracic curve also. This is preoperative shoulder level is actually very important because most of the patients would want to go and would like to have a good shoulder balance because this is what they see. So elevated right shoulder generally gets balanced. As I said, in type 1, type 3 and type 6, the proximal thoracic curve is flexible or minor or non-structural, so they will balance themselves. It's in 2 and 4, which is a problem, and basically in 2. So you will have to look at the tilt, the medial shoulder, the tilt, how stiff is the curve, and the T1 tilt and the clavicle tilt, and all that to take into action. There are some alpha and beta angles also been described, but that is too complex to describe here. So this is important to keep in mind. So the shoulder balance is very, very important. There are limitations of Lenke classifications, and we have been rule breakers a lot of times, especially when we want to leave the proximal thoracic curve or leave the more motion segments below. And if you get a balance right, you can get it right. So there are problems with this, and I think the end is not yet, because as more and more newer methodologies come in, 3D classification comes in, the EOS system comes in. I think Dr. Bhavuk Garg in AIMS has the EOS system where you can see from above that it is basically a rotational deformity, and that has been neglected in the Lenke's classification. And the age of onset also, and that has also been not so much emphasized in this classification. So these are two other things which will also come into play. Then the patient profile, the flexibility of the patient, the balance, all these come to the, so there are always lots of debates in the Lenke classification as to fusion levels, getting balance right. But obviously you should avoid coronal decompensation. You should avoid add-on, and you should avoid kyphosis, both proximal and distal junction. Thank you very much for your attention, and I'll take questions, though this is a virtual.
Thank you, Dr. Shankar, for a comprehensive cover-up of all the classification system that you mentioned across, along with the guidelines of management, both in terms of the upper instrumented vertebrae and lower instrumented vertebrae, with special emphasis on the shoulder balance. So a quick question for you, Dr. Shankar. When King's classification and when Lenke's classification? Because I'm sure there are people here who will swear by King's classification as one of the most successful ones.
I think in this virtual seminar, we shouldn't confuse people with the King's classification. King's classification is where we grew up, and we use that classification. But I think to make things less complicated, we should not confuse people. But King's classification was a thoracic classification. Basically for thoracic spine, it had a false double major and a true double major, a short thoracic curve and a long thoracic curve. So for the long thoracic curve, it was, so there were some good points in King's classification, but for this symposium, I think we should stick to the Lenke's. So I have not discussed the PUMC classification, the King's classification, and other classifications at all, just to keep this simple, because Lenke itself takes time to understand.
Right. And any quick tip to understand, memorize, and apply the Lenke's classification into practice, or it just takes its own learning curve, its own time?
The best tip is to keep the Lenke's classification in your clinic. I do still that in my home clinic and in my hospital clinic and in our duty room. So those who want to do scoliosis must know, and to have the software, the PACS software, to know how to measure the angles. So that is important. So getting the angles right.
Just while you were speaking, I was going and revising it on my phone.
Well, you are a master blaster, so you don't need to revise your. So, but it is important each time. So the way I have explained today is just trying to make it simpler for people to understand what is Lenke 1, how it becomes 2 or 3, then what is 4. and then 5 and 6. So first 4 are thoracic curves, and the 5th and 6th are lumbar curves.
Right, right. I think very simple and very important tip, Dr. Shankar. Thank you so much. Amit, I'll quickly come to you. When is Lenke's classification not applicable to spinal deformity patients? What are the cases where you should not rely on Lenke's classification?
I think Lanke's classification is basically for adolescent idiopathic scoliosis. So primarily it has to be used for AIS. So you must find out whether it's an AIS or it is other like syndromic or congenital ones. And if you have to rule out them, so you may use the principles of Lenke in selecting the fusion levels, but basically it is only used for adolescent idiopathic scoliosis, not for other like neuromuscular or syndromic or congenital ones. So that's
right. Again, focusing on Arvind's talk, clinical and radiological evaluation of spinal deformity is extremely, extremely important. It involves doing X-rays in a particular manner to not only find out what kind of curve it is, but also to assess the magnitude of the curve, the type of the curve, and so as to understand the guidelines of management. Lenke's classification comes very handy to choose the upper instrumented and lower instrumented levels and for correction of the curve. Ranjit, quickly running to you. What are the clinical and radiological factors that must alarm you that you are not dealing with idiopathic curve and this is rather a non-idiopathic curve and I should not be using Lenke's classification? What are those clinical and radiological markers? Is gender or any kind of skin patch or any X-ray finding that is very relevant to distinguish between idiopathic and non-idiopathic curves?
Yeah, so Vishal, to reiterate Dr. Shankar Acharya's statement, there are rules and principles. So when I look at a curve, first, all these classification Lenke give guidelines as to how to assess your plan of treatment. So apart from the classification, I look at the patient. When I see primarily a left-sided thoracic curve, the so-called historical reason for being a left convex thoracic curve, more than the more common right thoracic. If I see a left thoracic curve, number 2, a male patient, a male scoliosis. Number 3, when I see limb length discrepancy or when I see any pelvic obliquity, if I see a oblique takeoff of the lumbosacral junction, if I see caffeole patches or something atypical, ear tags, etc., I think in terms of this not being a classical idiopathic scoliosis. Many of the curves which we see and we call idiopathic, eventually when we follow up over time, even after surgery, we get to know that they are not idiopathic. There may be some kind of subtle syndrome which we don't know. Even when you look at those people, their skin is different, their hair is different. So these are the things which
neurological deficit, Kaplan spots,
then deficits,
joint flexibility.
And another thing on the X-ray, if I see the X-ray, I see significant vertebral rotation and not so much element of curve. Again, I think that this is not a typical.
Is kyphosis a regular feature?
A classical idiopathic scoliosis is a lordorscoliosis. So if I see a kyphoscoliosis, again, I think of neurofibroma. So the question first you asked was clinical. So clinically, these are things, and on X-ray, these are things, too much of rotation or too less of rotation, too much of angular kyphosis, angular scoliosis, or hypoplastic ribs or hypoplastic pedicles. These are features which tell me that this is not an idiopathic. Anyway, for me, all my patients will have an MRI. So I'll pick up if it is congenital or neuromuscular. But many a time I might miss a so-called syndromic one, subtle syndromic one, and call them idiopathic. I know them when they add on.
Right. Thank you, Ranjit. Thank you, Arvind. Thank you, Dr. Shankar Acharya, for bringing about some pertinent points about scoliosis, clinical and radiological evaluation, proper radiological evaluation, getting the magnitude right, getting the correct classification applied, knowing the exact type of curve, knowing the magnitude of the curve, and then planning the upper and lower instrumented vertebrae in typical idiopathic curves after you have distinguished them from atypical curves is extremely important. And this is something that we may pay attention to in almost all our cases. Now we know a curve, we know the classification, we know the upper and lower instrumented vertebrae as per the principles laid down by Lenke and described by Dr. Shankar. Now we want to correct it. What correction maneuvers to apply? How do we reduce these curves? How do we choose the type of correction maneuver, and what kind of osteotomies will come into picture? None other than Dr. Ramesh Chandra, who's going to tell us about surgical principles and reduction techniques, maneuver and osteotomies in spinal deformity. Dr. Ramesh Chandra.
Good evening. I would like to thank Dr. Sanjay sir, Dr. Anant and Jayesh for this opportunity. So I will be speaking on surgical principles of reduction techniques, maneuvers and osteotomies. So spinal deformity is a 3D abnormality. So understanding the 3D anatomy is crucial to plan the surgery. So the goal is to obtain a good functional and cosmetic result with minimal complications. So documentation is very important. Should document all the physical findings like shoulder abnormalities, rib hump, the torsion of the thoracic cavity, and etc. And the very important other important aspect is flexibility of the curve. So this determines the maneuvers and the osteotomies to be used. So you should know that how rigid or the flexible a curve is, and of course the classification of the curve. Followed in the operation theater, the most important thing is neuromonitoring. All these maneuvers and osteotomy has to be done under strict neuromonitoring. And next comes the tools. So without these tools, all these processes are not possible. So they range from rod reducers, tower reducers, vice grips, compressors, distractors, instrumenters, derotators, then osteotomy sets, various osteotomy sets, bone scalpel, and hemostatic agents. So I'll be speaking in these subheadings, the maneuvers, osteotomies, and others. The first thing is regional compression distraction. So discussed by Harrington. So distraction is done on the concave rod and the compression on the convex rod. Now, if you use this as a primary reduction maneuver, this may influence the sagittal balance. So basically, this is used as a fine-tuning maneuver nowadays. The next is the differential rod countering. So the differential contouring in the sagittal plane between the convex and concave rod creates what is called as a derotational force to the apical vertebra in an instrumented curve. So basically in a typical right convex curve, the goal is to pull the left-sided apical vertebra posteriorly and the convex right-sided apical vertebra anteriorly. So to produce this, hyperkyphosis is contoured on the left rod, whereas hypokyphosis is contoured into the right side. Next is the rod derotation maneuver. So the rod is contoured for the coronal plane deformity and is placed in the screws on the concave side of the deformity. The locking caps are engaged, but they are not fixed. And slowly the rod is rotated 90 degrees from the coronal to the sagittal plane. So for this, the prerequisites is the rod must be stiff and the bone must be strong enough and the spine must be flexible enough. So here it's a scoliosis deformity where the screws are placed. The rod is placed in the coronal alignment. It is hyperkyphosed and it is the screws are engaged using the tower reducers, but the set screws are not tightened. Now the rod is gripped with the vice grips and slowly the derotation is done. Now the derotation has to be done in slow increments and gradual increments in installments. So a 90 degrees rotation is done in 3 or 4 rotations. So this allows time for the viscoelastic creep to get in and then the spine conforms to the rod. And throughout the neuromonitoring should be done. And once the one vice grip is used to retain the position of the rod, the other vice grip is adjusted accordingly. So once we are when we are satisfied with the rotation as seen by the rod, then this can be fixed. All the set screws can be fixed. So this is the end product where once the concave rod has been rotated 90 degrees into sagittal plane, thus reducing the scoliosis. Now we can do the fine tuning by compression and distraction. So compression is done at the convex side and distraction is done at the concave side. So while doing this, you have to keep in mind the screw pull out. So always should be done very minimally under neuromonitoring. Now, next is the direct vertebral body derotation. So it's basically a 3-column control of the vertebra. So this actually pulls the concavity out of the chest, and when compared to the rod derotation maneuver, this corrects even in the transverse plane, unlike the rod derotation. So better rotation correction is obtained because it rotates in the axial plane, and better rib hump reduction is obtained. So this can be done in 2 ways: en-bloc vertebral body derotation and segmental vertebral body derotation. Now, en-bloc vertebral body derotation, the entire periapical segment of deformity force is applied to this. So, and all the segments are interlinked with various locking devices and cross links. Now, derotation in segmental vertebral body derotation maneuver is applied to an individual vertebral segment. So first, initially the lower instrumented vertebra, LIV, or the neutral vertebra is derotated, and all the vertebrae are derotated with respect to the neutral vertebra as moving cephalad towards the apex. So basically we have to match the neutral vertebra. So this image shows en bloc vertebral derotation, and this is a small short video showing the segmental vertebral body derotation, where the initial the lowermost vertebra is derotated and all the vertebra next are derotated sequentially from the lower end onwards. So this is a comparison between the pre and post operative images. So here you can see the axial plane of the axial CT, the rotation is significantly corrected in the post op images. Even in the intraoperatively, by a simple PA radiographic, posterior anterior radiographic image, we can see how much derotation has been obtained. So this shows that when both the screw tips are central to the two rods, it indicates 0 to 8 degree of vertebral rotation is still present. When the right screw tip is hidden by the right sided rod, it's 9 to 12 degrees. And if the right screw tip goes lateral to the right sided rod, as seen here, it indicates more than 13 degrees. Next is the rod translation. Here the rod is placed first in the distal or the proximal implants, and its orientation is sagittally oriented, and the rod is sequentially reduced into each implant. This can be done using reduction screws or rod reducers. So basically the reduction of the spine is done by pulling the spine into the rod. So the forces of reduction are distributed over each segment, and the only flexible curves you can do this. Another example, rod cantilevering. Here the rod is used as the lever pivoting on the apex of the curve, which acts as a fulcrum. This is more effective in kyphosis correction, and in useful in neuromuscular scoliosis where you have a huge flexible curves. Now, in situ bending is done in coronal and sagittal planes to improve the sagittal alignment. So coronal benders are usually used when you want to re-establish the coronal contour if the rod bends out during the rod re-rotation. And sagittal benders usually used to working a rod into the implants, where difficult rod to implant reductions are there, and also used to creating lumbar lordosis. So these are a few examples of idiopathic scoliosis corrected through various maneuvers. Now coming to the comprehensive anatomical spinal osteotomies classification was given by Schwab et al. And they divided into 6 types, where type 1 was inferior facetectomy, type 2 is basically Pontis, SP or PCO, 3 and 4 are PSOs, grade 5 and 6 come under VCR or vertebral coronary resections. Now, grade 1 is partial facet joint resection, where inferior facet is removed. So this is basically done in all levels in spinal deformity. It loosens the segment, it provides source for bone graft, enhances the fusion by the decortication of joint, and basically, most importantly, it helps to visualize the superior facet and the transverse process junction, and enables the freehand placement of screws. So here the junction is drilled and the pedicle is probed. Once the pedicle is probed, the pedicle probe is removed and directed medially to cannulate the body. So once the body is cannulated till the desired length, the screw is inserted. So by removing the inferior facet, you get a nice visualization of the junction. Next is grade 2, complete facet joint removal, where both the superior and inferior facets, the ligamentum flavum and a part of spine lamina and the spinous process are removed. So there are various names like Peterson osteotomies, Pontis osteotomies, posterior column osteotomies. So where there are subtle differences. The SPO was described in fused spine. Usually a single lumbar level is done, and basically indications are ankylosing spondylitis, rheumatoid arthritis, degenerative scoliosis. Pontis are used in non-fused spine, where multiple thoracic levels are done, basically in flexible scoliosis, Scheuermann kyphosis. And in degenerative, now posterior column osteotomies are used even in degenerative scoliosis, where to prevent iatrogenic lateral recess stenosis, where the patient may become symptomatic after restoration of the lordosis. So 10 to 15 degree correction per level is obtained by these SPOs, and approximately 1 degree correction per 1 mm of bone resected. So this video demonstrates Pontis osteotomy. So inferior facetectomy is done, the superior facets are exposed. Next, the lamina and part of the spinous process and part of lamina are removed to expose the ligamentum flavum. So once the ligamentum flavum is exposed, the ligamentum flavum is also resected on either side. After resecting the ligamentum flavum, the superior articular facets are cut and removed. So basically, we are disarticulating both the two vertebrae. This by removing the connections. So this can be done in 2 or 3 levels at the apex of the spine. Pedicle subsection osteotomy was described by Thomas in 1985. Basically, it's a V-shaped resection and a posterior shortening surgery. So it is resection of the posterior elements, pedicles, and the vertebral body. So, and basically indication is usually done in the lumbar spine. Indication substantial sagittal malalignment with and sharp angular kyphosis, and most importantly in patients who have undergone prior fusion that would preclude the performing SPOs. So 3-column osteotomy usually gives 30 degrees of correction per level. And based upon how much pedicle is removed, how much disc is removed, so this can be classified into 6 types. Here, this describes the procedure of the pedicle subsection osteotomy. So the posterior elements are removed, the pedicle is decancellated, and slowly the vertebral body is cut in a wedge-shaped pattern, which is then closed. Vertebral column resection first described in 1922 by McLennan. So there are many approaches for vestibular VCR, that's the anterior and posterior, but posterior only approach introduced by Suk has become familiarized and more common, and because the advantages in a posterior only approach are it's a lesser time consumption and lesser complications. This achieves, unlike the PSO, it achieves an anterior shortening of the spinal column, basically indicated in rigid spinal deformities in the coronal and sagittal plane. And it has a sharp, in case of sharp angular deformities, a single resection of single vertebral body with fusing a few levels is enough. But in broad deformities, resection of multiple vertebral levels at the apex is done and a longer fusion is used. So this is a short video. It's a complex vertebra deformity where 4 vertebrae were fused and had severe kyphosis. So basically, it starts with a costo transversectomy, where is the ribs are a part of a rib and the junction is removed. So the junction of the rib head with the transverse process and the pedicle is dissected with the chisel. And then each rib head is removed independently. So all the ribs involved in the deformity are removed. Hemostasis is secured as and when required. Next is the transverse process are nibbled out. Then the laminectomy is done. This laminectomy is done. Then the bone work is done to expose the roots. Now exposing the roots is very crucial because the roots will direct you to the underlying disc space where the osteotomy has to be done. And by taking the roots into sutures, the cord can be mobilized away from the osteotomies, so it can protect the. Then the lateral surface of the vertebral body is exposed. The osteotomies are done both cranially and caudally, and these osteotomies are connected using a bone scalpel, just lateral to the cord, and the bone is removed and blocked using a chisel. The anterior aspect of the vertebral body is exposed, and both this is done in bilaterally. And the central part of the this bone is removed using bone scalpel and drills. And the posterior part of the last part is dissected off from the cord, and it is broken down using various instruments. If it is thin, it can be done with a dissector, and if it is very thick, it could be done with a specialized instrument here. Now, ultimately, the completely cord should be free 360 degrees without any bones, and it should be freely hanging. This is the vertebral column resection. Now the measurements are taken and the appropriate cage is inserted. So these are a few examples of vertebral column resection for complex kyphotic deformities. Now the others, the thoracoplasty. So these are indicated in fixed curves where the flexibility is less than 20 degrees, curves more than 60 degrees, and the intraoperative curve correction is less than 50%. So limit to 3 to 4 bursts, the more the hump is palpated, and the most prominent ribs are palpated, and of the convex spine are palpated and resected. So and this is done through a plane between the thoracolumbar fascia and the longissimus muscle. Here you can see a complex kyphoscoliosis with a huge rib hump. Even after doing a VCR at that level, the rib hump was prominent, still prominent. So thoracoplasty was done, and this is the follow-up image showing after 2 years. So you can see the nice correction with the almost negligible rib hump. Another useful modality is the dynamic surgical guidance probe, the PediGuard. So basically it detects the pedicle breach in real time, and fluoroscopy can be avoided. So basically it's an ultrasound thing. It produces when the tip is in the cancerous bone, medium pitch and medium cadence is there. The moment reaching the cortical bone, you can see the voice. Once it breaches, you can get high pitch sound. 3D printing is another important aspect where complex deformities can be printed and intraoperatively can brought in so that you can have a better understanding of the deformity. Another aspect in 3D printing is pedicle screw templates. Basically, these give the relationship of the pedicle in relation to the spinous process. So you have to remove the whole soft tissue of the spinous process, just place this zig over the spinous process. That will trace, it's a basically way of navigation wherein it will trace the pedicles. So you can just drill through the holes, cannulate the holes, and then put the screws. So basically concluding, the maneuvers and osteotomies used depend on a lot of factors: the implant rod properties, implant bone interface, flexibility and rigidity of the curve. So you should keep a set of maneuvers for the primary correction and other maneuvers for fine tuning the correction. So good to master all the maneuvers and osteotomies and customize your skills for each patient, and all these should be performed under neuromonitoring. Thank you.
Thank you, Dr. Chandra. It was interesting to see a comprehensive description about various kind of osteotomies and their use in correction maneuvers. So my question to you is, what is the sequence exactly, like for a deformity which is 60 degree, 80 degree, and 100 degree? What is the sequence that you follow in correction of these three different kind of deformities, one by one? Maybe let's take it with 60 degree scoliotic deformity.
Basically, I'll see the rigidity or the flexibility of the curve, and so wherever the rigidity is there, I will try to do some Ponti's osteotomies and release them. And after putting the screws, so basically the differential rod rotation, I'll do hyperkyphose the concave rod, place it in the screws, try to fix it with the set screws without tightening them, and then do the rod derotation maneuver. And following this, depending upon the curve, like if there is a lot of rotation, I will do a en bloc derotation maneuver and then adjust it to super add the segmental derotation also if required in the later stage. But as the severity of the curve increases, like 80 degrees, more than that, we can use the minor correction maneuvers also, like compression, decompression, and my aim is to get a sweeping curve, not a very rigid straight correction for all this, so that basically what the other speakers have told, get a neutral vertebra in the cranially and as caudally.
Right, Dr. Shankar, may I have you on board to answer this question? Dr. Shankar, are you with us? No. Yes. So Dr. Shankar, at what threshold pre-operatively you start planning? Pre-operatively, I'm telling you, even before you have washed, but you have already planned in mind that this case is going to require osteotomy. Is there a specific criteria to tell you that these kind of curves, magnitude, flexibility? So what is the threshold when you start planning about osteotomy even before you wash up?
I think it is very important to have all your plans before you wash. So you need to know, first of all, the unusual curves, like I think Amit spoke about, or the left-sided curves or unusual curves, which are, though look idiopathic, are not idiopathic, and they have any spinal cord abnormalities and all. So first, that thing should be excluded in your mind. You should know that this is a pure idiopathic curve that I'm looking at. Second is looking at the stiffness of the curve and the associated kyphosis with it. So normally in my scoliosis, I don't tend to do VCR, frankly speaking. So very rigid curves, I I would still stick with Pontes and at best PSO, distally at lumbar levels to correct my curves. And but definitely Pontes for all the levels in the apex. So basically you need to look at the flexibility of the curve pre-op. You need to look at the balance of the curve pre-op. You need to look at the sagittal profile of the curve. You need to look at the length of the curve and the rotation of the curve, especially when the curves are very rigidly rotated, mainly at the apex, and the curve pedicle is very small and also got dysmorphogenesis, then you are worried about these curves.
Right.
And if a very hypokyphotic curve is there, you may not be able to bring it out. And as
Right.
Dr. Ramesh has shown very nicely, you will have to do a concave rib head resection, then cut one or two roots, then do Pontes, and then you can do SPOs, and then you can correct them. So you will have to plan them before.
Right. Thank you, Dr. Shankar, for bringing out the point that the stiffness of the curve, the magnitude of the curve, the length of fixation, all have to assess pre-operatively and plan your surgery in mind. It is never an intraoperative decision to do any kind of osteotomy. You have to plan it well in advance, and how do you plan and when do you plan are all these factors that you need to take into consideration.
Just
Arvind,
one point I want to say, that every time we do a scoliosis, there is a plain diagram hanging in the and the fellows who would scrub would have rehearsed this diagram and put it on this OT along with the X-ray to exactly tell me where the plan is, which is the last, which is the LIV, which is the UIV, where we have to do osteotomy, where we should do reduction screws, especially in the apex, what should be the length of the screws, everything they would plan and write on a pre-operative planning chart before we go for the scoliosis. So that should be there.
Well, very interesting. Thank you, Dr. Shankar. Arvind, let me come to you. We just spoke about the rigidity of the curves and intraoperative maneuvers. Are there things that you have in your practice have been doing pre-operatively to reduce the magnitude of osteotomies intraoperatively? Anything that you can do to increase the flexibility of the curve or reduce the requirement of osteotomies intraoperatively?
So two things you must have seen. I hardly believe in side bending X-rays. Even if it is a curve which is less than 60 degrees, traction X-ray gives me an entire idea as to how much of correction I'm going to get. Even the shoulder levels are best indicated by the traction X-ray. So traction, so I use intraoperative traction almost always for any curve which is more than about 75 to 80 degrees. So, and we use heavy traction. Half the body weight is divided into two. That is distributed between the two legs, and 1/3 of that will go to the head end. And before the patient, before the traction is applied and after the traction, we do neuromonitoring, MEPs to check. We take special care that, the eyes are not, actually because the traction is taking the stress in the horizontal direction, it is like a gliding position. So there is no much vertical pressure on the eyes. So this is what we do. It helps in many ways. One is it not only corrects the curve, it derotates the spine. So your exposure on the convex side becomes much more easier. And I'm not sure Subir is here, I don't know whether he practices, because we both learned from the same mentor. So the other thing is, convex side instrumentation, concave side instrumentation becomes slightly much more easier than, especially in those patients where the entire spine curve is collapsed, 110, 120 degrees. Basically the one half of the curve above is falling on the lower half. So it opens it like a book. So that straightens out the curve. So that is one thing. Second is the Pontes has been a game changer for most of us. So we used to just use traction initially, but traction plus Pontes maybe adds the correction by another 15 to 20%.
Right. Thank you, Arvind. May I now call upon Dr. Amit Jhala. Amit, intraoperatively now you have added 3-4 levels of Pontes, and still you feel the curve is still rigid. At what stage do you convert your osteotomy from a Pontes into a pedicle subtraction oblique anterior column resection?
I think whatever has been spoken by the previous speakers, it's very, very important to find out preoperatively that the flexibility of the curve is more than 50%, then there is no need for an osteotomy first, and that's a full stop. If the curve is less than 80 degree or 75 degree, then there is no need for an osteotomy. So what you are talking about is whenever the curve is more than 80 degrees or 100 degrees, And if the rigidity is less than 25, flexibility is less than 25%, then you have to consider that there is a requirement of an osteotomy. So once you do a Ponti's osteotomy, usually you do a periapical, maybe 4 to 6 levels of Ponti's, and then you try to correct it. If it does not come, but most of the time in AIS, at the most you may require is an asymmetrical pedicle subtraction osteotomy rather than a VCR. So after doing 6 or 7 Ponti's, you try to correct with the help of the by pushing the curve or the hump, and if it is not correcting much, then you may consider at the apical level, and that is what preoperatively you have to keep those. You don't have to put the screws at that apical level, because or you might have to remove it if you want to do an osteotomy at that apical level.
Right. Thank you, Dr. Amit. So now we have preoperative traction. We have intraoperative rod rotation maneuvers. We have intraoperative rod contouring maneuvers. We have compression distractions available. We have Ponte's osteotomy, PSOs, rib resection, and VCR to correct the deformity. The big question that here is, which Dr. Kaif, one of our delegates, is also asking. Jacob, may I have you on board to answer this question for Dr. Kaif and Dr. Asheesh? What is the end point of correction? How much should one surgeon aim to correct it? Because with all these correction maneuvers, actually, we can get a completely straight spine. Should that be our end point? Or what should be the end point? And how do we decide intraoperatively, no, that this is optimum and this is acceptable standard of care, and I don't want anything more than this to risk the spine? Dr. Jacob. Is Jacob with us? So, Ranjit, can you take that question for us, please? End point of correction, Ranjit?
Yes. Vishal, to answer that question, number one, that question about osteotomy, when do you stop, when do you go? All these decisions are based upon the mobility of your disc space. When I have a fused disc space, none of the Pontis or all these things will work. It has to be a VCR or a PSO, which seldom happens in a adolescent idiopathic scoliosis. So never will a situation arise where you have to convert your posterior column osteotomy, PCO, to a PSO or a VCR in an AIS. Second, coming to the correction, the goal of correction in AIS vis-a-vis rigid congenital or kyphotic is totally different. In AIS, my intra plan will never change from what I plan pre-op. My levels of fusion and fixation are decided pre-op on the standing, AP, lateral, bending, traction, whatever exercise. My screw levels are fixed. So my UIV and LIV will not change. Once I start my correction, once I see, provided that the neuromonitoring is fine, once I feel that I have got my spine balanced with respect to whatever maneuver I use, I stop there. If I feel that at some point of time, you all have noticed that the rod will give into the curve, not the curve coming into the rod. We always want the curve to come to the rod. At some point of time, you will see that you do whatever further rotation, the column will not move. Column will not move. That's where I will stop. Right. And there we do further maneuvers, the implant might pull out or you might end up with breaking the rod.
Right. Thank you, Ranjit. Ramesh, one quick question for you. Again, Dr. Asheesh from Delegates is asking this question. What is the acceptable residual deformity where you will not do much and accept, for example, a 120-degree curve, you did a Ponte's osteotomy, and at the end of multiple level Ponte's, your curve is still a residual correction comes out to 60-degree residual curve is there. Would you at this point add further osteotomy or you will accept it? What is your acceptable residual curve after correction maneuvers? Dr. Ramesh Chandra? Dr. Ramesh, can you take up that question, please?
Yeah, hello. Am I audible? Hello?
Yes, Dr. Ramesh, the question is, what is the acceptable residual deformity after your correction maneuvers are over?
Once the correction maneuvers are over, hello?
Yes, we are able to listen to you, Ramesh.
Yeah, I have some connection issue. Yeah. Okay. So basically, instead of measuring the amount of correction, I'd like to see how the central sacral vertical line is placed on the spine. So once it is almost touching it, I think I leave it there. And the concave, I compare the screws on the concave side and the convex side, see whether they are parallel to each other. Very difficult to get them completely parallel, but some distraction and compression can be given, and then that is where I think I stop. I don't really see the percentage of the curve.
Right, right. Arvind, one last question coming up from one of the delegate, Dr. Kaif. Role of neuromonitoring and neuronavigation in spinal deformity. You have been the pioneer in neuronavigation. Can you help us to understand the benefits of neuronavigation and neuromonitoring in spinal deformity surgery? Arvind.
So coming to neuromonitoring, so we have been using multimodal monitoring, the SSCPs and MEPs, and we've been fairly well. You know, it is you have to use it. It is pertinent, and it has to be compulsorily used when you do big deformities. And when it comes to navigation, so if it is an idiopathic scoliosis, it is very cumbersome to instrument all the levels with the screws. So I usually use it in congenital scoliosis, where there is a short segment fixation to be done, because you're going to instrument just a few levels above, few levels below, and you're going to compress and close the gap. So you need to have very good purchase of the implants, the screws. So you need to put big screws in the right direction. Plus, as you are operating, you need to know where the triangle of the hemivertebra ends. You know, otherwise, if you make a big hole, it will be difficult to close. So navigation helps in directing you with regards to, it gives you a direction as to where your superior end plate is, where your inferior end plate is of the hemivertebra, how it is rotated, etc. So it will prevent you from overdoing or underdoing the osteotomy.
Right, right. Thank you, Arvind. I think time has come to change gears from scoliosis back to kyphosis. Now we have a senior spine surgeon from Jabalpur, Dr. Asheesh Tandon, one of my very, very senior and close to heart. Dr. Asheesh, over to you for kyphosis and deformity correction, preoperative planning and assessment. Dr. Asheesh. AV team, may we have Dr. Asheesh Tandon's video, please?
Yeah, hi, Vishal. Thank you so much. And thanks to Anant and Jayesh as well. Just trying to get my screen share.
So while you come up, Asheesh, may I have one more question from delegates for Dr. Ramesh Chandra. Dr. Ramesh Chandra, are you there? So question is from Dr. Kaif. What is the role of staged surgeries? Do you always do a single stage marathon surgery where screws, osteotomy, closure, correction comes in same stage, or you sometimes have to stage it? And if the answer is yes, when? You're unmute, please, Dr. Venkat. Dr. Venkat, unmute, please. Yeah. While Asheesh comes up with his slides.
Yeah. Though literature states the stage surgeries are better in some instances, but I really don't have experience on these stage surgeries, because they say if the curve is very huge curve, so you can do the osteotomies, distract with temporary distraction, and then close, and then come back after a week or so for the proper correction, so that the huge curves get reduced. But I really don't have experience in those very huge curves.
Okay, thank you. Thank you, Dr. Venkat. We are back to Dr. Asheesh on complex thoracolumbar kyphotic deformities. Over to you, Asheesh.
Thank you once again. And I see a very senior panel of orthopedic and spine surgeons here, and very limited neurosurgeons. But that is how it is in India right now. I would be focusing on complex thoracolumbar kyphotic deformities and try to make it as simple as possible for a youngster wanting to enter into deformities. I'll start off with certain cases and the questions that one needs to ask. So here is a 35-year-old gentleman. He has been suffering from progressive kyphotic deformity for last 15 years, increasing severe pain from back to the flanks, And for last 1 year, he has observed increasing weakness in his lower limbs. And now for last 3 months, he has been bedridden. His motor power is 1/5, and he has a severe kyphoscoliotic deformity. We investigated him in detail, and this is the MRI picture. On the left lower side, you will appreciate that there appears to be recrudescence of the disease. So once you have this case, the questions that should crop up are, one, whether you need to go conservative or surgical. Conservative mainly whether you would be able to provide with a reasonable result. What would be the prognosis in the short and long term, the level and type of osteotomy, the degree of correction, and then how to tackle the lumbar roots while negotiating the cage. This is an entirely different spectrum. A lady in the 7th decade of life, persistent severe back pain with claudication, failure of conservative treatment in terms of blocks and medications. So here she has loss of lordosis. Now the challenges here are very different. The age, the severity of scoliosis, we are dealing with an osteoporotic spine, and then we have the lower inflection point in the lumbar area. Now, coming on to kyphosis, kyphosis is a normal curvature in the thoracic spine and sacrum, and the Cobb's angle varies between 20 to 40 degrees between T2 and T12. Whereas a kyphotic deformity is excessive forward rounding of the back. The jury is still out regarding the Cobb's angle as far as hyperkyphosis is concerned. And gibbous is a sharp angular deformity. But the overall picture is that it's only recently, over last maybe 2 to 3 decades or even less, that we have started appreciating the importance of correction of these sagittal deformities and their long-term outcome in deformity correction. To provide a very simplistic classification for kyphosis, we have congenital, where you have segmentation formation defects, Schauman's kyphosis. Then you have Angst-Pond, which is reasonably common, infective, pyogenic or tubercular and tuberculosis, and pot spine being one of the most commonly seen kyphotic causes of kyphotic deformities in our country, post-traumatic, osteoporosis, tumor, METs, and iatrogenic. So in fact, the topic for today is evaluation of kyphosis. Obviously, we have clinical examination and radiological examination. So we start with a visual evaluation of the patient, look for the coronal and sagittal alignment from patient's occiput to the pelvis, and in fact, lower down, looking to the hips and the knees as well. The next, you evaluate whether there's a hunchback, a rounded curve, or a gibbous. Look for range of motion from cervical to thoracic to lumbar spine. Notice open point tenderness if you have, if your patient has, and then obviously go on to neurological evaluation to find out the degree of compression and the power and jerks. Thereafter, you examine the patient walking, look for the hip and knee flexion when the patient is walking. And this would sort of indicate the compensation that the patient is trying to do for hyperkyphosis. As we all know that we are managing kyphosis, and one of the very important factors is falls, and the patient is trying to compensate by flexing to prevent falls. As far as radiological evaluation is concerned, you measure the C7 plumb line. The speakers before me have already discussed about it. The important thing is if the line is anterior to the sacrum, it's positive. And if it is falling behind the sacrum, it would be negative. Basically, it's a line drawn from center of the C7 to the posterior superior corner of S1. The structural evaluation is extremely important for surgical planning. You need to look at the degree of kyphosis, the number of vertebral levels or segments involved, especially when you're looking at a short segment disease. For long segment, obviously, you need to look at the whole structure, right from cervical spine to pelvis. Look for the flexibility, assess the flexibility of the curve, and then finally look for the global sagittal balance. Generally, we get standing X-rays. They have to be a whole spine X-ray with knees and full extension. You get a standing PAAP X-ray views as well as lateral views. For lateral, you need a large film. So that is very important. That is a practical aspect that you need to image the whole spine, include from the cervical region, lower occiput to the pelvis and proximal femur. Thereafter, in my practice, I go in for MRI in all the cases. You can add CT scan as well. Well, we all know that Cobb's angle is the gold standard. It's ideally it should be from T2 to T12, but we all know that on X-ray above T4, it's very difficult to visualize. So we measure from the superior end plate of T4 to inferior end plate of T12. I've already shown that the normal curvature that we think is normal for the young and adult is between 20 to 40 degrees. For elderly, it is on the higher side. And if it is above 50 degrees, we would label it as hyperkyphosis. Coming on to the spinopelvic parameters, we need to look at the pelvic tilt, sacral slope, and pelvic incidence. These are important parameters as far as the pelvic vertebra is concerned. So we consider pelvis as the base vertebra on which the whole spine has been constructed. So one needs to measure this to, these are the various lines. You look at the sacral slope, the pelvic tilt, and you add it to form the pelvic incidence. I would like to draw your attention to this paper. We use electronic or any handheld device to measure these angles. It's pretty fast, and you can even do it in your OPD. Now, coming on to why treat hyperkyphosis? Well, the balance is disrupted. There is increased postural sway. There's loss of energy. And because of all this, there's increased risk of fall. We also know that there is increased risk of vertebral fractures, secondary to increased pressure on the anterior part of the vertebra. There is mechanical restriction if there is severe kyphosis or kyphoscoliosis with dyspnea and decreased vital capacity. It's been well documented that there is higher risk of mortality as well. Obviously, all this adds up to lower quality of life, secondary to pain and decreased physical performance. Now, let's get on to the second part of the lecture, which is how to choose the patients for surgery and what are the indications. Well, unremitting pain is first. Thereafter, you have progressive neurological deficit in the patient, progression of deformity, and cosmesis. So what are these parameters for severe disability, wherein you definitely have to intervene and operate? It was Schwab et al. Who described that if the pelvic tilt is more than 22 degrees, SVA of more than 47 mm, or a mismatch between the pelvic incidence and lumbar lordosis of more than 11 degrees, then these parameters need to be considered as severe disability parameters, and you need to go in for surgery right away. Now, I've just highlighted a few of the common causes of kyphotic deformities and how do you choose. For post-traumatic kyphosis, apart from the TCIS classification, the surgical indication as far as kyphosis is concerned is if there is progressive deterioration in kyphosis or a progressive deterioration in the neurological condition of the patient, if the kyphotic angle is more than 30 degrees or the loss of anterior vertebral height being more than 50 degrees, it's time that you intervene surgically. As far as post-tubercular kyphosis is concerned, we know that it is basically there is paradiscal inflammation, which is the reason or the cause for anterior vertebral column height, which eventually leads to the kyphotic deformity. In pediatric population, there is higher risk of kyphosis, and the reason being cartilaginous vertebral body is prone to destruction along with the continued growth of the unaffected posterior column. So both of these come together, and the incidence of kyphotic deformity is more than 90 degrees in 10% of patients. So that's almost double the percentage as far as in comparison to adults, I'm sorry. Now, in children, the risk factors for exponential increase would be if the patient is younger than 7 years, if there is junctional involvement and thoracolumbar disease, and if there is loss of more than 2 vertebrae. So in this group of patient, the chances of increase or progression of the deformity is higher. So the indications in port spine are progressive neurological deficit, again, progressive spinal deformity, failed conservative treatment, you don't have a diagnosis, or there is severe pain secondary to abscess and instability. As far as Scheuermann's kyphosis is concerned, the management pearls include curve, which is again progressing or more than 70 degrees, or the patient has severe pain or neurological deficit. Now, coming to the aims of spinal deformity surgery, especially kyphosis, which is very true even for scoli, you have to achieve balance, relieve the pain of the patient, and then prevent recurrence or worsening of deformity. Obviously, all these three need to be taken care of, but not at the expense of any deterioration in neurological status. These are the various types of osteotomies and not part of my lecture. Posterior vertebral column resection is my workhorse. As far as severe deformities is concerned, I would skip this part. I'm sorry. This is the technique, and I'm pretty sure that the authors after me would be covering it. Well, this was the first case. I undertook vertebral column resection along with Pontes to sort of correct the deformity. Especially in severe deformities, you have to be aware that you cannot do too much of neural shortening, and you need to monitor all this through SSCPs and MEPs. After correction, you continue with the anti-tubercular therapy. So this was the pre-op, and this is the post-op which we could achieve. This is the patient almost 6 months after surgery. This was another case wherein there's degens scoli with kyphosis. You need to take the fusion above the dorsal lumbar junction to avoid failures. The coronal correction is important, but we now know that the pain would be resolved by correction of the kyphosis and achieving a lordotic spine. So this was the post-op. The third case is a pediatric case of 10-year-old girl, progressively increasing hump in the dorsal lumbar region. Paraparesis, the power being 4/5 and Cobb's angle of 60 degrees. This was her MRI. We had to undertake a 2-level vertebral column resection, all done through the posterior approach. Obviously, with two vertebra resected, we required a long cage, and there were a good number of lumbar roots. So in such a situation, I use the hunch and arlet technique. Again, I would request you to just go through this hunch and arlet technique. It's a very simple technique to insert the cage. And this is the post-op that we achieved. This is another lady, 25-year-old, with dorsolumbar pain, progressively increasing weakness for last 3 months, not able to walk for a month, with the Cobbs of 55. This was a CT scan with a good amount of anterior compression. This is the MRI with active infection. Again, PVCR at 1 level with an expandable cage and a 4-level fixation. This was an interesting case of a lady in 3rd decade with progressively low back pain with radiation into the posterior aspects of thigh. Neurologically, she was well preserved. She underwent a hysterectomy for this this condition, and when her pain was not resolved, she was investigated and then found with this deformity. There was L5 body destruction and angular kyphosis. Again, a posterior approach with an anterior cage placement and L2S2LR screws. To quickly summarize, for me, I prefer posterior only approach. The most popular approach I undertake apart from PVCR, Pontes. If I am doing a PVCR, then for more rigid curves, I feel Pontes helps. Again, I would like to emphasize that I find in my practice the hunch technique, wherein you place the cage between the roots, to be a useful adjunct for me. And you can achieve good to excellent outcome in pretty difficult deformities. For the youngsters, you need technical expertise, for which you need to join a good deformity surgeon. You need to have the infrastructure, which is a little different from what the neurosurgeons or neurosurgeons managing spine is like. Again, the whole length X-rays, intra-op neuromonitoring, the classification is different, the management strategies are different, but then you need to get that into your armamentarium. Thank you so much.
Thank you, Asheesh, for a wonderful selection of cases highlighting the importance and variety of kyphosis, not only the etiological classification that came up in the form of various type of cases, be it post-tubercular, post-traumatic, post-deformity, degenerative, pathological, and various other causes of kyphosis. You wonderfully dealt with cases one by one. You also showed us about the importance of various type of osteotomies, be it wet lesions or the healed ones, and of course the nuances of surgical correction modalities here. There is a question for you, Asheesh, here is, again, very similarly in kyphosis, correction is not based on objective criteria. It is rather subjective. It is based on surgeon's ability to correct it and also certain intraoperative decisions. Though on one hand, all the surgeons and of course the patient wants a completely straight spine, on the other hand, there are surgical factors which preclude you from complete surgical correction. So how do we find a real-time balance preoperatively of how much to correct and when should we stop while correcting the kyphotic deformity?
Okay, that's a very good question. And surgeons, when they are starting off their practice, be it for tumors or deformities or whatever, are too enthusiastic in correcting it and or treating the pathology. But there needs to be a balance. Again, I use intra-op neuromonitoring, and it helps if there is overcorrection or too much of neural shortening or any deterioration, you are able to get that, and you can sort of reduce your correction there and then. As well as preoperative decision making is concerned, you need to study the radiological parameters and the condition of the patient preoperatively, and thereafter you can make a decision based on what the sagittal and coronal balance is, how is the pelvis there, which level, whether it's junctional or the lumbar level, and on these criteria you basically make a decision. Obviously, too much of correction is not advisable.
Right, Ashish. So, what are the specifics that you pay attention to when you're dealing with a pediatric kyphosis in comparison to adult kyphosis? This question comes from Dr. Achal, who's sitting with us among the delegates. Dr. Achal. Dr. Ashish, your question is differences and specifics between adult versus pediatric kyphotic deformity.
Okay, first of all, I do not have a lot of experience as far as pediatric deformity is concerned. I have very limited experience, and also I try and avoid doing pediatric cases less than about 7-8 years of age. However, above that, I am more comfortable. The important things that we need to look is the crankshaft phenomena. That is very important. The instrumentation that you have to use, because the need of the instruments of the implants very different in an adult vis-a-vis pediatric. You need to have that equipment with you in hand. Similarly, fusion is pretty good in pediatric patients. And so what I would again suggest here is, for pediatric patients above the age of 7 to 10 years, you can go for a little shorter sort of fusion as compared to long fusion segments.
Right. Bringing this to Arvind's point, Arvind mentioned about the lower safe surgical vertebrae in kyphosis correction. The lower instrumented vertebrae should be chosen with care in all these patients while keeping the instrumentation sanct. Dr. Amit Jhala, are you there with us? There is a question here coming up. Dr. Amit Jhala. So now on one hand, we saw different type of etiologies of kyphosis. We also heard about the different type of kyphosis correction maneuvers, and we have to have a fine balance between complete correction versus optimal correction here. And we also heard about the role of neuromonitoring and cord buckling here. Are there some ways of preoperatively determining that this particular type of kyphosis is more prone to develop neurological deterioration, and X, Y, and Z factors should be taken into consideration to prevent neurological worsening in these particular type of kyphosis? Dr. Amit, over to you.
So I'll just grossly classify these into two types. One is a rounded kyphosis and other is an angular kyphosis. So once you are correcting a rounded kyphosis, the chances of getting the neurological problems are very, very less, because in rounded kyphosis, you are correcting at multiple levels at a small degrees, like in Schwann's kyphosis or something like that. Vis-a-vis, if we are doing a post-tuber kyphosis where there's a sharp angular, or a congenital ones where there's a sharp angular kyphosis, there is a point kyphosis at one particular level. And if you see preoperatively angular kyphosis more than 60, 70 or 80 degrees, then you have to be very, very careful that this patients may have, or you have to be very careful perioperatively that they may go for a post-operative deficit, which is much more in kyphotic than in scoliosis patients. So whether it's a kyphosis which is rounded or a sharp angular, that is one thing. Coming to the perioperative things, you have to be very gradual in correction of a sharp kyphosis. I always, there are two factors. One is you have to do a complete release from posterior anterior, but then you cannot just do a buckling and compression from the posterior side. You have to have anterior column, a cage or anterior lever, so that the cord does not buckle, and you have to every time see that the cord is not getting buckled, the dura is not buckling, and therefore put a lever in the front, either a distractor or a cage, and then compress. And I usually use the reduction screws so that I have a very gradual correction which is possible. And I will leave it if there is a lot of buckling. If the neuromonitoring says that you have to stop, I'll leave it at that particular point, because in kyphosis, the deformity correction is not that much important like in scoliosis, right? You can leave a little bit kyphosis and the patients are happy about it. So
Right.
this is what I'm talking about, more than 80 or 90 degrees of kyphosis.
Right. Very important. I think this message should carry home to all of us. Though there are different type of kyphosis, different etiologies of kyphosis. Broadly, kyphosis classified into round back kyphosis or angular kyphosis. And both these type of kyphosis are extremely different entities, and you have to correct them in a different manner. One requires more of Ponte's correction at multiple level, whereas one requires PSO and VCRs. Whenever doing PSO and VCRs or even Ponte's osteotomy, remember, kyphosis complete correction is not the aim. Optimal correction is the aim, and residual kyphosis of almost 30 to 40 degrees can be accepted. The aim should be somewhere around 50 to 60% of correction. There are factors pre-operatively and intraoperatively to judge when to stop your correction or when to stop or consider it as an endpoint, which involves knowing when to stop, buckling of the cord, mobilization of the cord, and neuromonitoring signals are all pointers that can really be help when to stop in there. Gururaj, one last question to you, because I know you're going to come up with your video on kyphosis correction. The question here is, there are many patients who come to us with spastic paraplegia and kyphosis in thoracolumbar or in thoracic spine, where neuromonitoring cannot pick up any baseline and is of probably no help. In those situations, what are the guiding factors about the end point of kyphosis correction?
Actually, when you have a spastic paraparesis, you always, it's not assumed that you don't get signals. You always try to get your signals. If at all you are not at all getting any signals, then SSCPs will help in. Usually the MEPs are multimodal monitoring. SSCPs will help. So when you have SSCPs, then you can monitor with the SSCPs. Otherwise, these cords which have a spastic paraparesis are the sick cords. We have to be very, very careful when we operate in these patients. That's what when Dr. Jala was pointing, I wanted to tell that whenever you have a preoperative neurological deficit, we have to be very, very careful, because these are the patients who worsen more as compared to people who don't have any neurological deficits. So whenever we are doing deformity correction in these patients, we actually, it all depends on how many osteotomies you have to do and how many laminectomies you are doing. As Dr. Jala said, if you have to compress or shorten the cord more than 1.5 vertebral levels, then always have an anterior lever and then don't shorten the cord too much. So there is no one factor which guides you where to stop. You have to consider all these factors and then decide where to stop.
Yes. To summarize, yes, Asheesh, one summarizing.
As far as this point is concerned, I would like to emphasize the use of sham rod, and that is very important. So at all times, that has to be there for you to get the support and prevention of sudden buckling or damage to the cord.
Right, very important. I think all the points here are absolutely pertinent. Kyphosis is a completely different and a difficult entity. Despite the best measures that we discussed, 20% neurological worsening is known to happen in surgical corrections of kyphosis. More so in adult population, different type of kyphosis are known. Round back and acute angular kyphosis are two completely separate entities to be dealt with differently. However, the basic principles of correction, from osteotomies, rod maneuvering, differential rod sequential bending maneuvers, correction with the help of Ponte's, PSO and VCR, and when to use anterior column has been dissected, and also role of neuromonitoring we just discussed in detail. Let's follow all these principles while we are dealing with kyphosis, while we shift on our gears back to scoliosis and the surgical strategies for scoliosis correction by none other than Dr. Ranjit Unnikrishnan. Ranjit, over to you.
Thank you, Vishal. Can you hear me?
Yes, we can hear you and see you as well.
Okay, lads. And the PowerPoint is seen, right?
Yes, that's right. Okay. Your slide has to start.
Okay, thanks very much. So Very interesting session. So when we look at these three type of scoliosis, we know that we have.
Your slide has to go on full mode, please.
It's not in full.
Slide show. Yeah.
It's not in full mode.
No, it is not in full mode. We are seeing a slideshow. Yeah. Now. Yes, it is better.
Now, no, now it's not in full mode.
Not yet.
Now it's done.
Not yet.
Okay, so I'll probably have to unshare and share again.
Please do that. Yeah. So we'll go through the second last talk, which is on surgical strategies for scoliosis, followed by Gururaj, who's going to talk to us about the video technique of how to correct kyphosis to complete the session there. And we can see the slide here, Ranjit. Yes, please.
Is it in full mode?
We can see slide 1 and 2 both together. So maybe you can just want to play it. Use slideshow. On the left hand of the screen, use slideshow.
Yeah, I was there.
Yes, now ready.
Okay, fine. Thanks very much. Yeah. So when you look at these three kind of deformities, you know that you have to have a different strategy. You also know that you have to have a different technique. You also know that you have to have different kind of implants and instruments ready. So this is supposed to be a talk on surgical steps and video presentation. So I'll go through the steps on a slide-based show because that makes more sense than showing a running video. So these are the three different type of curves. So we totally have a different mindset when we start this, like the previous speaker mentioned. So just recap of principles, it has to have good pre-op planning. But exactly what do you mean pre-op planning? Knowing your levels and your correction strategy and your bending levels correct. This is a very important point. You have to have generous soft tissue and bony release. If you try to go and pull and push on a rigid curve with nothing released, your implant is going to fail. So you have to take up a good release. We'll see it. What is it? And you have to have strong anchors in the strategic vertebrae. We heard Dr. Shankar Acharya's talk where he spoke about all the strategic vertebrae and how to decide the levels. And show really strong anchors. If your screws are not holding well, you cannot expect any great correction. You have to use the appropriate maneuver, like the previous speaker who gave an excellent presentation of all the techniques of correction and with all the equipment. And this is very important. We heard Dr. Arvind Kulkarni say at the outset that balance is everything. He spoke about cone of balance and all that. So you have to try and achieve the balance and make sure that whatever we do, you end up with a fusion. So each part of this procedure is very important. If you do a good correction, don't fuse well, you end up with a pseudoarthrosis. So that is not welcome. Now, this is a very, very important point when you come to adult or adolescent deformity correction. This part, the most important part is not the fused area, but how the unfused area behaves with respect to fused area. Meaning, look at the middle part. You have a harmonious curve correction. Your lumbar spine compensates. Look at the last part of the image. You have a straight fused spine. So your lumbar spine ends up straight, and that ends up with a poor outcome. So today we know that one single thing which matters in the long-term outcome of deformity surgery is sagittal plane. So HRQLs totally depend upon your sagittal plane correction, not your coronal plane correction. So this should be kept in mind whenever you plan any kind of correction strategies. So the three things which I will not go again. So first thing, when I start the surgery pre-op is to make sure that I explain the wake up to my patient because my neuromonitoring can fail. So every patient I tell that you have to have, we might wake you up and tell them how to do the wake up test. Second, make sure I got adequate PRBCs ready. I have to have the patient's photographs and consent checked up. I also have the surgical plan with my screw strategy printed in the paper and stuck to the IV stand, which I look up frequently. And before posting, I make sure I have the baseline MEP SSCP, have a catheter inside. I always use tranexamic acid at the dose of 30 mg per kg in adults and 20 mg per kg in children, which is an infusion followed by 10 mg per kg infusion throughout the surgery. This has decreased my blood loss significantly. I hardly end up giving 1 unit of transfusion in a D2 to L2 curve. Use antibiotic prior to insulin, all standard protocols. And we have this IONM checklist stuck in the theater. So what to do when we have a alert in the neuromonitoring, which is available in the website. I will not go to the details of that. When I present the machine, I use a Wilson frame or Jackson frame, both of them. Make sure that the bony prominence are padded very well. Make sure that the eye is padded very well, because that's very important. And always get an IONM, your MEP levels done after you prone the position, especially in a neuromuscular curve. You might lose signals when you have this, or your baseline might change. So I have to get it done. Then is the incision. You can use a straight incision or curved incision. I use a straight incision. I get standard exposure. In a pediatric patient, I split the epiphysis with a knife so that I get real subperiosteal elevation. You have to have tip-to-tip exposure. That is, tip of the transverse to the tip of the transverse process, and keep the MAP around 60 to 70 to make sure that you don't lose much of blood when you expose. Pack it up all pretty much regular. This point requires care. At the upper level, you don't want any PJK or a proximal junction kyphosis, all the more relevant in adult scoliosis than adolescent scoliosis. So I try and keep all the supra and interspinous ligaments intact at the top two segments, and I also don't do a pontis or a facetectomy at that levels. I preserve the facet capsule with a lot of care, because this is the only thing which we can do with respect to soft tissue preservance in a AIS to prevent the PJK. And always make sure you adequately expose especially at the upper level, because you are going in, when you have to go to a D2, your upper curve is in kyphosis. So you tend to you have to bend your instrument to get your trajectory correct. There, don't pull and push, do a liberal skin incision, and don't damage the capsule and the suprainterspinous to get your screw inside. It's a very important point to avoid retraction. If not, they'll end up with a dirty scar there, because the neckline, most of them are females. So the neck, around the dress, you'll see a bad scar there with a beautiful scar in the midline. So that's very important. You would take care of that. Once I expose everything, I put one screw. I, as a matter of fact, always try to put the screw at the D12 if it is a thoracolumbar curve, if I have to go, because from there, there are many people who ridicule using a C-arm in scoliosis. After I put my screw freehand, I make a AP shoot and count my levels from there. So it's counted, checked by two people, me, my assistant, and the nurse. So we all make sure that my screw is correct so that I don't miss anything. I have missed it earlier. So that is a check which we do. Then we go ahead. Next, after exposure is released. Nothing goes inside, no implant goes inside until I release properly. So this should be followed methodically. It's been different classifications, whatever you do. For me, that I do a facetectomy first. I remove the inferior facet. I use an osteotome. If you have a mesonics like the previous speaker, so it's very good, decreases blood loss. I don't have a mesonics, so I use an osteotome that gives me enough bone to form a fusion. So do an inferior facetectomy that will expose my facet, the so-called Mohs osteotomy, and make my entry point clear. And in places where I plan to do a posterior column release, I do a pontis. A pontis is nothing but an extended kind of facetectomy with suprainterspinous release. I do a pontis. I remember when I do a pontis, I'm expected for blood loss. That is a place where I will go inside the canal. So I keep things ready for the bleeding to be controlled. Now, this is exactly what I remove in a case of posterior column osteotomy. What do you call it, pontis or PC or whatever. So once that is one of the pros of using a pontis is that you kind of lengthen or shorten. The posterior column is under your control. It bleeds a bit more than your normal inferior facetectomy, but I get better correction of my thoracic kyphosis, and I get better correction of my lumbar lordosis, because I'm going to shorten the lumbar column and lengthen the thoracic column, which is more easier when you do a pontis. So conceptually, after you've done a pontis, the only thing holding the vertebra together is the annulus in the front. The rest, all you release, the costotransverse joint, you release the facet joint, supraspinous. Today with the liberal pontis, I hardly have to do any kind of osteotomies and on the discal level to get your column corrected in an AIS case, which is not a pleasant thing to do because they bleed a lot and got more complication rate. So then you can choose whichever strategy you chose for your screw insertion. Once I have got my things released, I basically go into a strategic vertebra. I try to have 2 screws in every strategic vertebra, which kinds of comes at your screw density around 1.5. That is your choice, whatever thing you are trained in, you're comfortable. but this should be very sure all the strategic vertebrae, wherein the apical, the UIV, the LIV, and all the peri-apical concave and convex should have screws inside, because that helps you in do your direct vertebral rotation or whatever. In this, my primary maneuver of choice of doing scoliosis AIS correction is translation, sagittal as well as coronal. I don't use rod rotation for rigid curves. Rod rotation is used only for very, very flexible curves, even though I trained classically doing a rod rotation. So I do a sequential reduction using the towers or whatever thing that particular equipment starts. So that is done by rod. I try and always use a Covalcom rod, because that is bent high. The concave rod is bent more than the convex rod, because my concave is the pulling side and my convex is my pushing side. I repeat, my concave is the pulling side, convex is the pushing side for a thoracic curve. So it is started. I start the engagement from one of the ends and gradually keep going towards the center and come down. And all these equipments help me do it sequentially. Whenever I do, you can see this. One of the assistant holds the rod. It is locked onto the screw. Plus, one of the assistants holds with a rod grip, because the rod should not rotate when you try to pull it up. And you gradually get the screw one by one into the rod. Basically, you get the curve into the rod. In a very rigid curve, you can see that at some point of time, the rod starts going down into the curve. So this is how you do. You gradually cantilever them one by one. You get them reduced into the rod. And then after I've done my rod reduction, then I always do direct vertebral rotation. I hardly do a costectomy or a costoplasty today for an adolescent curve after I learned how to do a DVR properly. Doing a DVR properly is a technique which you have to learn. When I do a DVR, we have four people. We have four people who have to do a DVR. Number one, the rod is locked inside, it's inside the captures. The lowest end is tightened. You should keep the upper end free, because if not, it will not be able to derotate. Two rod grippers go on the rod. Then this picture, which is classically the Medtronic picture when it was described, I use rod grippers, two of them, and one assistant holds both the rod together. Second guy puts in the towers inside like this, and with the cross connection connected. The third guy gives a push on the rib hump so that my corrective force is dispersed between the implant and the physical push. And the fourth guy tightens the screw. I repeat, one person holds both these rod holders together and holds it to the foundation. The second person does the towers with the cross connected and rotate it. Third person pushes on the rib hump. Fourth person tightens the screw. So this sequence we follow at each level. You start at the edges and go to the center. Why? Because the center or the apex is the most rotated vertebra, or the end or the edge is the least rotated vertebra. We are doing rod direct vertebral rotation. So we go from the least rotated to the most rotated. So I don't do an en-bloc VCM, because I feel that's too much stress on the implant. So I do from the edge gradually. As you come to the center, you find that the apex is quite a lot derotated, and that helps you less stress on your screws. So once that is done, you make sure that all your capsules are tightened very well. Or these are the things which I mentioned. If I use a hyper concave rod on the concave side, or a hypo concave bend rod on the convex side, to make sure that I get my vertebral derotation corrected. Because whatever you do in scoliosis, whatever maneuver you follow, you are trying to do a transverse plane correction. You are trying to derotate the vertebra. So this is the way how it is done. Once that is done, I look at my shoulder balance. I make sure that the shoulder balance and the caudal balance is done. I use the cautery, cortex, whatever thing you're comfortable with. I make sure that my shoulder is balanced. I take a C-arm shoot at this stage, see that my caudal disc is parallel, my shoulder, my cephalic disc is parallel. This leads to a big can of worms. Does upper UIV
equal to shoulder balance. It is not a debate for this session. So I try to match my LIV to UIV parallelism. And then at this point, if I'm tired, I take a break. Why? Because the real surgery starts now. If I don't do a meticulous fusion, my surgery failed. So by this time, if I'm tired, I take a break, have coffee, come back, and then do the decortication, do the fusion, and then do a closure. So this, remember, whatever you do inside the spine, if you give a dirty scar, more so in a female patient, they will curse you for life. The patient doesn't look at all these things, they look at the scar here. So this should be done very meticulously with patients. So that's where you need to take a break or have somebody else close for you who does a good job to look at the upper end of this. Too much of retraction leads to a sore there, and that leads to a bar scar and a keloid. Couple of cases, these ones where you see large rigid ones hardly doing anything, any action on the bending X-rays. You do them. We do a kind of Pontes, and can see Pontes at every level. One of our earlier patients, 2009. So go, and this is where we had got a significant correction without doing any column osteotomy. This is it. And remember this, prerequisite for a successful correction maneuver in AIS is adequate release. Again, repeat, adequate release, strong anchors, and a solid fusion. This should be hammered into our minds each time that this is the way it should go. Another patient, these kind of large curves when you know that your classical thing of rotation extra will not work here. So this, look at the CT of this patient, had hardly anything on the convex chest. So we went ahead, we gave pre-op halo traction, and then went ahead and did an osteotomy. A posterior osteotomy did not touch her chest. I didn't want to touch her chest with this. If I do a thoracotomy, that's an end for her. And this is how we got it corrected. And this is how she was immediately post-op on day 10. Another, like the previous speaker showed, now when you have this kind of curve, elderly, female, they come with pain more than with deformity, normal neuro. If you look at it, significant harm. So this is not a classical AIS. These are the ones who had some component of congenital which grow into adult and end up with a significant coronal and sagittal imbalance. You know that whatever you do, unless you release the bony column, you will not get a correction in these patients. So there we went ahead, we went and did a 3-level vertebral column resection in this. And you look at this is a classical way when you look at the 2 or 3 level VCR done for a scoliosis. The C-arm or the X look very ugly. The cage look out of plane because you have corrected the deformity. It's a multi-apical deformity. And this is how the finally the child is, you get about significant amount of correction in these patients. So to conclude, you have to have meticulous planning, judicious use of anterior, posterior, or anterior and posterior releases. Often needs combination of many maneuvers. You cannot succumb or say that I only use translation and not you have to mix all your maneuvers, compression, distraction, everything. You have to resort to sometimes to complex instrument strategies, dual rod, triple rod, etc. And when you deal with this, a complex nerve curve needs complex techniques. So when I believe this is primarily focused on the residents or starting surgeons in spine surgery with deformities. So choose your case very well. Don't start a case unless you discuss, get into one of those forums or get help, discuss your cases, because the level you think might be different than the level somebody else thinks who's more doing it regularly. So get help, plan everything, and get him to stop with you for a couple of cases. Then start your own, because the most sad thing is to come out of a deformity with a complicated, because like what Dr. Vishal Kulkarni mentioned, deformity surgery is one of the most rewarding surgery in spine surgery. Thank you for your patient listening.
Thank you, Ranjit, for wonderful elucidation of the practical knowledge of all the points and nuances that we discussed since this evening. We got to know about the etiology of scoliosis right when Arvind came into picture. We heard about the clinical and radiological evaluation and the parameters that are need to be checked in. How do we classify these scoliotic curves into different kind of curves in a comprehensive manner by Dr. Shankar Acharya, where he told us about not only the type of curves, but also the guidelines for selecting the upper and the lower instrumented vertebrae. We heard Dr. Ramesh Chandra about the correction maneuvers right from rod rotation, translation, rod contouring to the corrective osteotomies there. And then we saw Dr. Ranjit telling us about the practical application of all these principles that we heard from the previous speakers. Thank you, Ranjit, for bringing about those wonderful surgical maneuvers of release and bringing out the comprehensive methodology of rod rotation, rod contouring, and also about derotation maneuver that he brought about, along with the importance of neuromonitoring in these cases. Thank you, Ranjit. We will take up questions after the last talk of the day, which is by Dr. Gururaj S, who's going to tell us about kyphosis correction surgical videos step by step. Over to you, Dr. Gururaj.
Good evening, all. Myself, Dr. Gururaj S, working as Senior Consultant and Unit Head at Indian Spinal Injury Center, New Delhi. At the outset, I would like to thank the organizers for giving me this opportunity to present a video on kyphotic deformity correction. This is my patient, 13-year-old. He had a history of a hump in the lower back since birth, difficulty in lying supine, and deformity is gradually increasing since then. So his developmental milestones were normal. There was no history of any weakness in the lower limbs, no history of any other neurological deficits, and there is no history of suggestive of any previous medical or surgical illness, and he is a salesman by occupation. On examination, he had a rounded kyphotic deformity at dorsolumbar spine. He had a generalized ligamentous laxity suggested by hyperextension in the bilateral knee and bilateral flexible flat foot, bilateral hallux valgus, and bilateral genu valgus. Arm span was more than its height, and Steinberg sign was positive, thumb sign was positive, and there was no neurological deficits. That means basically he had a Marfanoid features. So this is his clinical picture. You can see there's a rounded kyphotic deformity there, rounded kyphotic deformity. These are his bending films. So you can see there is an exaggerated kyphotic deformity on bending. So this is his AP X-ray. There's a mild scoliotic deformity there. And this is his lateral whole length X-ray. The apex was around at L2, and there is a wedging of the vertebra there. And the deformity was almost 67 degrees, measured from T12 to L3. So this is his dynamic X-rays, that is basically prone X-rays. It looks like flexible. This is his MRI. You can see that there's a wedging at L2. And this is his CT scan. You can see there's again at wedging at L2, and there is a kyphotic deformity at apex at L2. And this is foot end, and this is right side, this is left side, this is head end. So we plan to do 3 level above and 2 level below, and the whole length of the spine was exposed till the exposure of the spinous processes, and we started putting our pedicle screws from L4 down. So I usually tend to use a 30D diamond burr to put my pedicle screws, especially in deformity cases, because it gives me a very good control, and it gives me a very good tactile feel. If you see when I go in and out technique, it gives me very good tactile feel, and it helps me in putting these screws without C-arm. But you can, in your initial cases, you can use your C-arm. And usually try to direct your screws towards the apex of the deformity, especially in kyphotic deformities, because the direction of these screws also help you in correcting deformity. So that's the Lenke probe. And then you feel for all your 5 walls. This is like any other pedicle screws, but only you have to be careful of the rotations and the superior-inferior angulation. So once that is done, you tap it, and then feel for again all the 5 walls. And especially in hyperlaxatic individuals, you have to be careful when you are putting your pedicle screws. Don't put too much of pressure on the spine because it's very, very lax, and support it well. And I typically tend to use all reduction screws for kyphotic deformity corrections, because it helps me in putting my temporary rod, and it also helps me in correcting my deformities at the end. So this is the L4 screw which is going in. And then this is again L3. You can see that's the diamond tip burr. And you can actually use like any other conventional method, you can use a awl, and then you can use a Lenke probe and do it. So in this case, there was not much of a patient was thin and lean. There was not much of a muscle cover. But then sometimes in kyphotic deformities, the lower screws can be really deep, and then the apical screws will be really below the skin itself. So you have to be, again, when you put your screws, you have to take care that once you correct your deformities, the screws shouldn't be actually basically pressing on the skin. That's a straight probe which I used here. Then you again tap it, especially when I don't use C-arm, I tend to tap them. But if I'm using a C-arm, then if I'm really sure that where I'm there, so I can actually avoid using tap. So then again, I'm using a reduction screws there. This is L3. You can see that spine is really, really lax, and it's moving with the screw. And but then if it moves like this, it goes on to show that the screw hold is also really, really good. So the other screws are being put on the opposite side. You can go 3 level below and 3 level above, especially when it comes to dorsal spine, where it really doesn't matter whether the movement is happening or not, because in lumbar spine, you have to try to save levels. That is why we are going 2 level below and 3 level above. Once these are the screws which have been put in L1, D12 and D11. And now we are starting the decompression, that is midline decompression. You take away the spinous processes and then start doing your laminectomy. So the newer technique is you can actually leave the lamina intact and do your all anterior work, and in the end you take down your lamina. So that actually they say that it protects the cord and decreases the chances of neurological deficits. So this is the temporary rod being put. It is under contoured, and we don't tighten. You tighten one end and don't tighten completely at other end. And the laminectomy has been completed, and you can see that the cord is pulsating very well there. So whenever you are doing osteotomy for a kyphotic deformity, depending upon the deformity, you might have to do 1 level above and 1 level below laminectomy, or sometimes 2 level above and 2 level below a laminectomy, depending upon how much of vertebral body loss is there anteriorly, or how much of deformity correction you are going to do. Because if you do only 1 level laminectomy, or if you do inadequate laminectomy, when you correct your deformity, the spinal cord can get inked in these areas where the laminectomy ends. So you might have to do some extra laminectomies above and below. So that's the spine now. So the temporary rod is being put there, and this is where the pedicle is being taken down. And there's the root is there. That's the pedicle. This is the L1 root, and there will be L2 root here. Here, I'm not going to sacrifice my root because these roots are very important. If at all in dorsal spine, you can sacrifice the roots and it becomes easy to do an anterior job. But then here, because it's a L1 and L2, you have to protect your nerve roots. And that's the, you can see how it is contoured, and that is the X-ray. So that's the root of L1, and that is the pedicle area of L2. So what we are planning to do here is a bone disc osteotomy. We are going to take down the basically pedicle of the L2 and then go inside and take down L1, L2 disc and a superior end plate of the basically L2. So we are just checking for the flexibility of the deformity here. You see that it's relatively flexible, but still if you see in the X-ray, it is not completely correcting. So we'll have to proceed with our osteotomy plan. So that's the spoon retractor, which is there in the deformity set of Medtronics. It really helps you in basically retracting all the soft tissues around the vertebral body, and this spoon goes anterior to the vertebral body and protects all the vital structures around this area. So that's the L2 pedicle partially is already taken down, and this is a partial L2 pedicle is preserved there. And then you start taking down the pedicle along with the superior end plate of the L2 as much as required. So when you can also use actually a high speed burr. I usually tend to use a high speed burr, but this is for the demonstration purpose using osteotomy. With the osteotomy, there's usually a more bleeding as compared to when you use a high speed burr, because high speed burr, when it rotates, it creates some heat and then it coagulates the vessels also. So the bleeding is lesser when you use a high speed burr. So you take down, and then you can see it under the Siam where you're going down. So that's our plan is to take down the bone like this and this disc out, bone disc osteotomy, and correct this deformity. So we are going to change the direction of the osteotome and take down bit by bit. But if you do a large osteotomy, then taking out this bone from this small window between L1 and L2 root becomes difficult. So take it by taking it by piece, piecemeal. And always bleeding is the problem here. So you have to be very, very careful. So you use a neuromonitoring in all deformity corrections. You see that all the signals are coming very well. So there is no decrease in the signals. So continuously keep monitoring in during each step. And that's the L1 root, and we are going above the L1 root into the L1, L2 disc. So that's the K wire just to identify. And then your procedure is something similar to T-lift there. Take out the disc, L1, L2 disc from there. You can use T-lift shavers to do that, because disc is very, very strongly adhered to the bones in these kind of deformities. So it really becomes bone is easier to take down, but then disc becomes really difficult to take out. So that's the shaver being used. Here this this is just protecting the cord. It's not retracting. So at this level, you have to be very careful. Don't retract too much. It's just protecting the root and the cord. So once you have done that, so you have taken down the disc on that side and the L2 superior end plate, and then you put a temporary rod on that side, and now you go to the opposite side. And then again, you start taking down the L2 pedicle there. So here I'm extending the lamina a bit because this was kinking the fecal sac there at L3. And then this is the pedicle of L2. So when you try to do this, be very, very careful not to inadvertently catch the root. because these, if you injure these roots, your flexors become weak. So be careful when you do this. In dorsal spine, it really doesn't matter if you ligate them and cut them. But then there also you have to be careful not to avulse the root from the cord. Otherwise, you can have a persistent CSF leak there. So again, the osteotomy is being completed on the opposite side also. The bone disc osteotomy. So taking out the disc there. And the posterior part of the disc and the posterior wall of this L2 end plate, which are taken in the end, because you don't want to take them in initially and then cord really sags, and it increases the chances of neurological deficits in the post-operative period. Here we are not taking away too much of bone, and really cord really doesn't sag, but in sometimes in a tubercular deformity where you are taking down 2-3 vertebral bodies, really the cord sags if you take it out very initial phase, then it causes neurological deficits. And taking that down also increases cord handling. So that also increases chances of post-operative neurological deficits. So now we are doing suction from this side. There is a connection. We have completed our osteotomy. And when you do this, be very, very careful not to go too much anteriorly and catch major vessels there. And we are checking whether the anterior epidural space is clear or not. So once that is done, again, you will put back your rod, which is under contoured on both sides, and tighten on the one side. And then again, you can sequentially go on reducing the other side. And then now you do compression, sequential compressions under neuromonitoring. After each few millimeters of compression, you should always check signals and in the neuromonitoring, whether they are the amplitude and is coming right or not. So there we are doing compression. And you do this, you can do this basically simultaneously on both sides or one after the other on both sides. You can see this deformity is getting corrected there. So you do compression on this side now. Then again, after finishing compression on this side, then again you'll go back and do compression, and you can see that the deformity is getting corrected there, and the last compression on this side. And then you do your final tightening. You see this rod was initially shorter. Now after the compression and deformity correction, this rod is actually looking a little longer. So that's the correction. You can see it's beautifully corrected. Thank you.
Thank you, Dr. Gururaj. It was in fact a complete thing, and that brings in to the end of the day. The SGPGI Comprehensive Spine Course started well in time, bang at 9:59 today morning, and today we are at 6:20 now, ending this day up with the session on spine deformity. Before we end the day, may I call upon Dr. Amit Jhala to please give us the summary statement on kyphosis management skill tips and tricks. Dr. Amit Jhala, over to you.
Yeah, so it was a very nice, I would say, I would like to, first of all, congratulate Jayesh and Sanjay Bihari and the team of SGPGI to conduct this course, especially on deformity. And it's a very specialized course, and everything was discussed right from the basics to the advanced level of the deformity correction. And especially in the kyphosis, all the speakers like Dr. Asheesh Tandon and Dr. Gururaj both discussed about how to evaluate the sagittal deformity preoperatively, what are the types of deformity, especially as well as in pediatric as well as in adults, and what are the deformities like rounded and the kyphosis rounded as well as the angular kyphosis, how to deal with both of them, what are the precautions that needs to be taken preoperatively as well as intraoperatively to correct these deformities, and a very nice video which was shown by Gururaj of a type of a deformity like bone disc osteotomy. There are so many osteotomies to do and correct the kyphosis deformity, and each and every aspect of the deformity was very nicely dealt by all the speakers. And I thank all the speakers and the SGPGI team for a very nice session on the deformity, especially the kyphosis. All the aspects were.
Thank you, Dr. Amit, for a wonderful summary session. May I now call upon Dr. Arvind Kulkarni, the opening batsman of spine deformity session, to please give a summary statement on scoliosis and its management. Arvind.
Yeah, thank you very much. First of all, I want to thank and appreciate Vishal's role here. He disguised himself as a beginner, though he is himself a great deformity surgeon. He disguised himself in the role of a beginner and asked very pertinent questions. And I also thank Dr. Jayesh, Dr. Sanjay Bihari, and the entire SGPGI team for keeping us busy the last 2 days. From A to Z of spine, you covered everything. So coming to scoliosis, this is very important. It was, I think, in the beginning of 2000, Amit may be knowing that Bridwell invited the neurosurgeons to join the SRS long back in the early 2001 or 2002. So then now many SRS members are neurosurgeons. So it is very nice to know that your keen interest in updating yourself with scoliosis. You saw Asheesh doing brave surgeries on kyphosis. So with regards to scoliosis, it's very important to they come in various different shapes and sizes. You need to classify them as pediatric and adult. Both have different indications, and mostly adult is a different kettle of fish. The coronal imbalance usually not a complaint. They usually come with sagittal imbalance. That is when you discover they also have degenerative scoliosis. When it comes to kids, it's very important to rule out. The main indication there is usually generally cosmesis. It's very important to clinically as well as radiologically differentiate AIS from syndromic and congenital deformities. Again, there are different kettle of fish with a different protocol altogether. And when it comes to idiopathic, it's very important. Things which we didn't cover today was basically EOS as well as early onset scoliosis as well as conservative management. I could have stretched this session furthermore, but you should also know when to conserve them. So once they reach a point, usually the rule of thumb is, more than 40 degrees during growth period and more than 45 degrees after reserve 5, after skeletal maturity. That is when, this is generalization, that is where you correct the deformity. So the main goal of deformity correction is to not to try to do heroism. It's basically to prevent further progression of scoliosis. So you need a solid fusion, and based on different grades of severity, you need to bring in different maneuvers to correct this particular deformity, from just putting screws to all the way doing a vertebrectomy. So everything has been enumerated today by Dr. Shankar Acharya, Dr. Ramesh, Dr. Ranjit, very beautifully, and there's no stone left unturned to comprehensively discuss everything about AIS today. Thank you.
Thank you, Arvind. Being on time is a wonderful thing, and that's what SGPGI Comprehensive Spine Course is all about. May I take this opportunity to thank from all of us, the whole team of SGPGI, who conducted a wonderful course and kept the course on time by managing the faculty members, being on time and bringing out wonderful discussion. Thank you, the panelists. Thank you, Dr. Amit, Dr. Jacob. Thank you so much, all the speakers of the session, Dr. Arvind, Jacob, Ranjit, Gururaj, Asheesh, Chandran, and everybody. Thank you so much for being around in a wonderful session. Back to you, Jayesh and Anant, for conducting this session.
Yes.
First of all, Dr. Vishal, for moderating the session beautifully, and it was one of the most informative sessions we had, primarily because, as Dr. Arvind rightly mentioned, that many of the spine surgeons, they don't do deformity correction and they don't have the basic concepts of the deformity correction. That was one of the reasons why we wanted to have this session, and that is one of the reasons why we wanted to have all these stalwarts like you and the other speakers, so that we can have the basic concepts of spine surgery and deformity correction. Thank you, Dr. Vishal, for conducting it beautifully.
First of all, Dr. Vishal, I would like to thank you personally for a wonderful moderation. Everybody well appreciated and really well engaging. And from my side and our team, SGPGI, Dr. Arvind Kulkarni and Dr. Amit Jala, we really honored Dr. Shankar Acharya with your presence.
So with this, we come to the end of the academics, and as is customary, we would like to give the vote of thanks. Firstly, I would like to thank all the faculty members, including the speakers, the moderators, and the panelists. I know some of the faculty members who were COVID positive or their relatives were COVID positive, but still they braved the disease and decided to be a part of the conference. And I again thank all the faculty members for sparing their precious time and being a part of the conference. Thank you so much. Secondly, I would like to thank all the delegates for their faith in us and having faith in the academic content that we had drawn. Without the delegates, no conference can be a success, and we thank all the delegates once again for having faith on us. Thank you so much. As we all know, COVID has ravaged the entire country, and our department was no exception. Many of our faculty members, postdoctoral fellows, and residents were, and actually a few of us still COVID positive. Some of the faculty members and residents even lost their near and dear ones. But despite the COVID and the person loss, all the residents, PDFs, and faculty members contributed immensely to the success of the conference. And I'm extremely thankful to all the faculty, PDS, and residents for the hard work they had put in. Although all the residents and PDF have contributed to the success for the conference, but I would like to take a few names as they worked tirelessly for the conference. Dr. Priyadarshi, Dr. Ashish, Dr. Ashutosh, Dr. Maruti Nandan, Dr. Kamlesh, Dr. Soman, and Dr. Vandan. We sincerely thank you all for especially putting so much of effort tirelessly during your COVID, non-COVID duties, during your elective surgeries, everything. And despite all of this, you worked tirelessly to make the conference success. Thank you all. We thank all the residents once again. In a virtual conference, the technical support plays a very important role, and I would like to thank Mr. Bahal and his team for providing the technical support, as it is because of them that the conference could be conducted seamlessly. We also take this opportunity to thank the telemedicine department of SGPGI for providing the logistic support. Thank you very much. Last but not the least, without the support of the pharmaceutical companies, and the conference would not have been conducted. And we thank the Dyson Pharma and the Medtronics for their support, especially the logistic support. I thank you all once again for being a part of this conference and making this conference a success. And with this, we come to the end of the conference. Stay safe. Thank you very much.